This conference will now be recorded.
For the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also the further instructions. Coalesce Research Group LLC is very delighted to welcome you all, the speakers, supporting associations, students, and delegates present virtually with us today. With the aim of mark the scientific excellence by facilitation, conversation, sharing knowledge, Coalesce Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries. Promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, engineering, and technology. Within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people across the world from their respective fields that they haven't connected in a while. As a global scientific event organizer, we plan and carry out international conferences, meetings, seminars, symposium, and workshops, providing the best delegate experience, excellent networking opportunities, conversations leading to innovations, learning new opportunities, lasting working relationships, and professionalization with the professionals around the global network. Just recently, we have also started our own platform for open access peer-reviewed scholarly literature, where all the content is freely available without any charge to the reader. We aim to share the new recent advances through scientific publications, which will help in minimizing the borders and contributing the use of research works of eminent authors, scientists, researchers, research scholars, students, etc., across a broad spectrum of medical, clinical, pharma, and engineering scientific disciplines and its subspecialties to promote the ideas which will guide the development and facilitate the use of scientific information and also ensure its quality and also will be the connecting link between researchers and scientific community. We are committed in ensuring that our journals are disseminated worldwide so that the researchers are able to access our content wherever and whenever they need it. As being a very few journals, we have coined up some interesting journals and have also formed the editorial board. We will be very glad if any of our today's attendees, the speakers, students, or delegates, could extend your support by clicking the journals and will be interested in publishing an inaugural issue at any of the journals according to your area of expertise. We will also send an email with all the details about the journal after the commencement of webinar. Do take your time to check the website. Finally, I would like to thank all the attendees and participants of today's webinar and hope you enjoyed the webinar and gain knowledge from the sessions. We also hope your participation will contribute to new research findings and that will lead to new collaborations and research initiatives. Before we start with the sessions, I guess some of you will be new to the GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app web page, you can find 4 icons at the bottom: mic, camera, screen, and end. Mic, click on that to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, you can use this button to share on unscreen the web camera. If you have the option to share the webcam, you can do it, or it is completely your choice. Screen, you can use this button to share your screen. This is the main part. During your presentation, after I call your name, from my side, I will be making you the presenter, and only I give you the permission, you will be able to share your screen. So once I make you the presenter, you can click on the screen button and you will be finding a pop-up window to share your screen. And this is your 4th icon where you can use this to leave the sessions. On the top center, you can use the options to change your display settings. At the top right corner, you will have 3 icons: people, chat, and settings. In the chat option, you can chat with me or any other participants. For the settings, you can use this button to check for the settings of your speakers and microphone. So as mentioned, kindly remain muted during the presentation so that the presenters don't get disturbed, and for any questions, you can ask them the questions or you can send your questions in the message box too. Well, let's not take much of your time. Finally, I would like to request you, please give us a brief description about yourself before starting with sessions so that we can have knowledge about you virtually. And now let's move into our sessions. And today's first session is presented by Dr. Simone Pereira Morias from Portugal. Hello, Dr. Simone. Are you ready with your presentation?
Yes, I am. Thank you.
Hello?
Yes. Are you hearing me?
Yes, yes.
Okay.
So I'm going to make you the presenter.
Okay, so I can start my sharing my screen and present, isn't it?
Yes.
Okay, thank you.
Yes, now you're the presenter.
Okay.
Please share your screen with us.
I don't know how to put it.
Yes, your screen is visible to us.
Yes, I know, but okay, let me see. I have this corner that I want to collapse. Okay, it is that. Can I start?
Yes, you can start.
Okay, thank you. Good day and good morning for everyone. It's a pleasure to be here to talk about firefighters' occupational exposure using biometering of polycyclic aromatic hydrocarbons metabolites. Firefighting is among the most dangerous occupation, being regarded as possible carcinogen to humans by the International Agency for Research on Cancer and also by the US National Institute for Occupational Safety and Health. Every fire is unique due to the materials that are burned and also due to the ventilation profile. But however, all fires produce many compounds in a complex mixture of gases and particulates. Some of them are polycyclic aromatic hydrocarbons that are among the most health relevant pollutants that are emitted during fires, and they are a group of organic compounds with 2 and more aromatic rings. They are already about more than 200 compounds have already been identified from belonging to this group, but still only 16 have been classified by US EPA as priority pollutants. One of them is benzoylpyrene, here indicated in blue. It is classified as known carcinogen, and also there are more 7 indicated here in yellow that are classified as probable and possible carcinogens. Moreover, there are new findings on more potent PEH, including, and some of them are not included in this US EPA priority list. These compounds are cytotoxic, mutagenic, and carcinogenic. They may have short-term health effects, such as inflammation, but also long-term health effects, such as gene mutation, cell damaging, cardiopulmonary mortality, but also skin, lung, bladder, and gastrointestinal cancer. pH, these compounds are emitted, as I told you previously, by natural sources such as forest fires, but also volcanic eruptions and fossil fuels. So firefighters will be occupationally exposed to these compounds through several sources, but also by through anthropogenic sources such as all the incomplete combustion of organic matter or pyrolysis, some industrial processes and burning of domestic fuels, and also traffic emissions and also tobacco smoke, between others. Distribution of pH are distributed between the gaseous and particulate matter phase. And this distribution is influenced by physical, chemical properties of each compound, but also by the atmospheric conditions, so temperature, pressure, and so on. So in the gas phase, we will have the low weight compounds that are usually the less toxic, but still they are able to react with other pollutants to form other compounds, other products, of which toxicity may be much more significant than the original compound. In the particulate phase of the air, we will have the mostly the heavier compounds, those that have 5 or more rings, and they are the most hazardous. Usually, the toxicity of these compounds increases as the number of rings increases, with the exception of naphthalene that has only 2 rings, and it is classified as a possible carcinogen. So in the particulate phase, we'll have deposition in a respiratory tract will depend on the particle size. So the evaluation of pH in the smallest particulate fraction is highly health relevant because of the ability of these particles to deposit deeply in the respiratory airways. Moreover, the smaller the particle size, the higher the toxicity for mechanism of oxidative stress and inflammation. So we can say that pH might contribute to or even increase the particulate matter health effects. So exposure to fire emissions have been associated with health risks for firefighting forces, such as aggravation, development of cardiovascular and respiratory disease, increase of morbidity and mortality. However, the causal relation between exposure to fire emissions and firefighters' health risks is still unclear, and these limitations need to be urgently tackled to improve risk assessment and support the implementation of better preventive strategies. So to have an assessment of a comprehensive exposure assessment, we should determine pollutants in external media, but mainly and also whenever possible to determine the total personal exposure using biomarkers in the several biological fluids. In terms of pH, these compounds are absorbed and distributed by blood routes to several tissues, especially to lipophilic ones. They are metabolized to a complex mixture of different products with higher polarity, which are then excreted through urine, feces, and sweat, being urine the most applied matrix for biomonitoring. So biomonitoring has been progressively assumed as a precious tool to assess firefighters' total exposure. The main of our study was to assess the impact of firefighting activities on levels of the urinary pH metabolites. For that, we did some sampling campaigns that were performed at 6 different fire stations from cities of the district of Bragança, which is one of the most affected Portuguese regions by forest fires. 153 healthy firefighters, non-smoking and non-exposed to tobacco smoke firefighters were selected, and only subjects whose diet at home did not include barbecue, and deep fried foods within 2 days before urine sample collection were considered. Based on the information from questionnaires, subjects were split in 2 groups, non-exposed and exposed. So the non-exposed groups are subjects that didn't participate in firefighting activities within 48 hours before the urine collection, while the exposed group corresponded to subjects involved in firefighting activities. 6 metabolites were selected. They were selected based on the importance of the respective pH. So 1-hydroxypyrene, that is a biomarker, it is considered the biomarker of exposure to pH. 3-hydroxybenzoapyrene, that is a biomarker of exposure to carcinogenic pH, and other more 4 compounds, metabolites of other more 4 compounds, because this pH are found in different matrices. These compounds pH are ubiquitous, so they are found in all type of matrices. Concerning the results, we can see that in terms of detection rates, whole values are higher than 80% for all 6 metabolites, with the exception of 3-hydroxybenzoapyrene that was not detected. This result is in agreement with other studies that have shown that this compound that has 5 rings is mostly excreted in the feces, and that's why most possibly it was not detected here. Moreover, also we know that pH can be bioaccumulated mainly in lipophilic tissues, so they may not be immediately metabolized. If we look at the half-life, the data that exist about the pharmacokinetics parameters of the pH metabolites are very limited and will depend on the route of exposure and excretion. But we may see that we have values ranging from 2 hours until 35 hours, and also data about inhalation exposure is very rare. So this lack of information difficult the establishment of collection times of the samples. Also, regarding the results, we can see that uranic concentration of metabolites varied inversely with the molecular weight of their respective compounds, meaning that the higher levels were detected in the compounds that have a lower number of molecular rings. We can see that also that urani-hydroxynaphthalene and 1-hydroxyasneftine corresponded to more than 60% until 98% of the total concentration of metabolites. And we can see that also 1-hydroxypyrene, that is a metabolite considered as a biomarker of exposure to pH, was only detected between 0.3 and 10%, corresponds only to 0.3 to 10% of the total metabolite. Moreover, if we look at the total value total concentration of metabolites, we can see that exposed subjects have about 35 times higher values of metabolites than those that didn't participate in fire combat activities. So suggesting clear evidence of the impact of participation in fire combat activities on the levels of these pollutants. Also, if we look at the trend of for each compound, we can see that after participation in fire combat activities, the distribution of the compounds was changed, and the lower compounds, the percentage of lower of compounds with lower number of rings increased, while others decreases. We can see also that 1-hydroxypyrene contributed the less to the total sum of metabolites and presented the lowest percentage increase between non-exposed and exposed firefighters. But still, the detected levels were well below the proposed guideline for occupational exposure to PEH. We test also some correlations, and we found that we had moderate to strong correlations between individual and total metabolites concentration for the majority of subjects. So we identified that there is a prevalence of an emission source to these subjects. Comparing our data with previous studies, we did a search in the last 5 years corresponding to the scientific literature published between 2015 and 2020 in the main scientific database, using the keywords occupational exposure, firefighting, biomonitoring, biomarkers of exposure, and firefighters' health, and only studies that included firefighters' occupational exposure or exposure during firefighting training by monitoring were included. Only 18 studies were found, and we can see that most of them are related with wildland firefighters, and only 2 concern structural firefighters. So we can see that clearly there are some research gaps in this area. Okay, here I present you the uranic concentration based on the 18 studies that were reported in the literature. Only 10 of them characterize the pre-exposure levels and also the post-exposure levels that are presented here, pre-exposure in the first plot and the post-exposure in the second plot. And we can see that there is a trend that after participation in combat activities, we can see that the levels of 1-hydroxypyrene, the compound that is considered the biomarker of exposure to PEH, are increased, but still they are the main results, so the main data are still below the biological exposure index limit set at 0.5. So the major findings can see that biomonitoring has been demonstrating firefighters' occupational exposure to pH by the increased levels of different biomarkers of exposure in different firefighting scenarios. We can see also that when we compare the levels of exposed and non-exposed firefighters with the levels detected in the general population, we can see that the levels are much higher in firefighters than in general population. So showing clearly that they are exposed to these compounds. Also, positive and significant correlations were detected between particulate matter bound pH and their corresponding urinary metabolites, and also positive and strong relationships between firefighters' metabolites level in urine and skin pH concentration after fire suppression activities, showing that there is some dermal absorption. Some final remarks. There is some limited information on pH of occupational exposure of firefighters. There is a lack of information on relationship between ambient concentration and personal exposure. Also, can one hydroxypyrin, the biomarker of exposure to pH, solely be used for evaluation of total pH the context of firefighting is still missing. So clearly, more studies are needed to better evaluate occupational exposure to fire emissions and support the implementation of different mitigation strategies to promote firefighter safety and health. Moreover, to address some of these research gaps, we are now working in a new project that has as main goals the establishment of panel of biomarkers of exposure and also effects for the surveillance of occupational exposure and firefighter health and safety, and also to establish a list of recommendations, good practices based on health relevance evidence. So thank you for your attention and all the best from Portugal.
Thank you, Dr. Simon, for your presentation. It was a nice presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presence and your presentation.
Thank you very much.
Yeah. Moving on to our next presenter, that is Dr. Freda Dokuş from Turkey. Hello, Dr. Freda. Are you ready with your presentation?
Yes, I would like to screen.
Yes, I'm going to. Yes, now you can share your screen with us.
Yeah, I think it's okay.
No, it's not visible, doctor.
You can't see?
No.
I will try.
Okay. Is it asking for any permissions?
I try to open, but why not open? 1 minute. What? How can I open it?
Can I know what screen it is asking? Like I have given you the permission to share your screen. Is it asking for any permission on your computer?
1 minute. And 1 minute. Here.
Ne yapacağım?
Screen. Not now.
Sistem preferansı aç.
Sure.
Şuradan yetki vermen lazım.
Sorry, I am waiting for.
Or else once leave the session and once again rejoin the session.
No. It will.
Okay.
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 Dene şimdi. Start de. Dene. Nasıl yapılıyor bilmiyorum.
Hayır.
Olmuyor. Sunamayacağım.
Yeah, I'm sorry, I can't open.
Nerede o sistem şeyi? Açık görünüyor aslında. Bulamadım. Nasıl yapılıyor? Yok. Screen. Open sistemde. Şuna. Ha. Olmuyor mu?
Uh-uh.
Benim bilgisayarım.
Problem, Dr. Freda.
Yeah, I'm so sorry. I can't open, but I don't know why.
Okay, you can do one thing. You can send your presentation to the mail ID of Nicholas Fletcher. We will play on your behalf and you can explain from there. I will
Okay.
share my screen with your presentation. You can explain it. Whenever you will say to move on the slide, I will move forward.
I will send by email, okay?
Yes, yes. You can send it to the email up to Nicholas. I will play on your behalf and you can start your explanation from there. Please let me know once you are sent with your presentation. I will take from the Nicholas.
Okay, okay.
Furkan. Hello, Dr. Freda.
Yeah,
Duymuyorsun.
I am trying to
Okay.
send by email. Okay.
Yes, yes. Please send. Once you are done with sending, please let me know.
Okay, okay.
Gönder.
Okay.
Şuraya ek yap. Nerede göndereceğim şimdi? Ya 114 MB muhtemelen göndermeyecek. En fazla 41 diyor çünkü.
Nasıl
Dene bakalım
göndereceğim?
göndermeyi.
Gönder. Neydi o konu?
Gittim bekle bakalım. Bekle. Gönderme kutusunu aç. Aç resmini.
Yeah, Resina, I sent.
Yeah, okay, Dr. Freda.
Can you open?
Yes, yes. Just a minute. I'm going to take it from the Nicholas.
I am very sorry.
Kilişe şifre.
Bence oydu. Doğru yaptım.
Açık işte.
Demin doğru yaptım.
Açık görünüyor.
Demin doğru yaptım. Şuraya yapsam. Bir dakika.
O değil.
O değil.
Parola
Şuraya.
koydum. Kapat onu. Parola koydum bir şey.
Abi bak. Ses açık.
Neye basmıştı? Açık.
Şurada. Şuraya yapsam.
Hangisi? Karıştı.
Hello, Dr. Freda. Can I know to which mail ID you have sent your presentation?
Yeah, I sent my presentation.
Nasıl alacağım bu linki? Alamıyorum burada.
Can I know the mail ID?
Yeah, I sent.
Hangi maile gönderdin diyor. Hangi
I,
maile gönderdin diyor.
I will stay 1 minute.
Okay.
Mhm. Occupational health email.
Okay.
2000,
Occupational health
2000. Yeah,
20 at the rate. After that, what is the mail ID?
yeah.
Can you spell the total mail ID name?
The name is Ferda Dokustu.
No, I'm just asking the mail ID full name, that is Occupational Health 2021 at after at what is the domain name?
Yeah, I will say.
Okay. Okay, we received your presentation. Give me a moment. Yes, we received your presentation.
You can see?
Yes.
Okay.
Just a minute, we are playing.
Okay. Can you open it?
Nicholas, yes, we received your presentation. Give me a moment.
Burada duruyor program.
Nerede program? Kapattın galiba.
Yok yok. Şu neymiş?
Neredeler?
Şu neymiş?
Ne diyor?
Sistem tercihlerini aç dedik.
Ha, belki de oydu.
Evet. Şimdi yapayım.
Yok ki.
Yok.
Vermiyor. Onu aç diyecektin. Açtı mı acaba? Aç bakayım sistem tercihlerini.
delay as the file is very
I can't hear your voice very well. You,
Senin bilgisayarda problem var.
you cannot open it.
Bilgisayarın şu an internete gitti galiba. Problem var. Ses gelmiyor. Benim bilgisayardan gireyim mi?
Yok var.
Yeah, sorry for the delay as the file is very big. It is
So that's why you cannot open it. Büyük olduğu için açamıyorum diyor.
Benim bilgisayardan gireyim ya.
Gir bakayım. Can you open it?
yes, I'm going to share my screen now. Please let me know it is visible
Yeah.
to all or not.
Yes, it is.
Is it visible to everyone?
I'm seeing
I
your
can
screen,
see.
yes.
Hello, Dr. Reda.
Hello, hello. I can see your computer page.
Hello.
Hello.
Başka bir bilgisayarda değil mi?
Hmm.
Yeah, hello everyone.
Yes, hello.
My voice is audible to everyone?
Yes, your voice, yes, but we are not seeing your screen.
I'm going to share my screen now.
Okay, perfect.
Yes, I'm going to play the presentation, Dr. Freda. You can start explaining that.
Yeah.
Tamam işte. Mikrofonun
Yes.
açık mı senin?
So I think I cannot control from here.
Tamam.
So
o yüzden
somebody will change for
No,
me.
you cannot control from there. You can let me know. I will change the slides for you.
Okay. So I think now I can start. I'm right.
Yes, you can start your presentation.
First, I want to say hello to everyone, and I am very sorry about this delay. But I hope my presentation will be useful for you. And you can change the slide. Yeah.
full screen yaptı.
Okay. My presentation today is about effects of workplace-based physical exercise programs to promote health. Our main subjects are health promotion, workplace health promotion, and workplace-based exercise. Change, please. And also, I will highlight how the workplace-based exercise program, that is one of the interventions of health promotion, can be integrated into occupational health implementations. Change, please. What is health promotion? Health promotion is a key element of public health and is guiding concept. It is the process of enabling people to increase control over the determinations of health and thereby improve their health. It covers a wide range of social and environmental interventions local and organization supports. Participation is essential to sustain health promotion action. Actions are directed strengthening the skills and capabilities of individuals' health behaviors. Nowadays, the incidence of chronic disease such as cardiovascular disease, respiratory disease, diabetes, stroke, rheumatological disease, and depression is high and continues to increase. On the other side, the reports show that over 60% of Americans are not regularly active, and that 25% are not at all. In Turkey, this rate is even higher. Over 70% of population, 67% men and 75% women do not regularly exercise, and 47% are not at all. People habituation of healthy lifestyles is important in preventing obesity and chronic disease. So, cognitive behavioral capacity is important in health promotion. Health promotion can be applied in the community, in the clinic or hospital, and in all other service settings. Change, please. One of the setting areas of health promotion is workplace. Could you change the slide? And again, change, please. The workplace is an important setting for health protection, health promotion, and disease prevention interventions that reduces the health risks of the employee. Change, please. When we look at the attributes of workplace health promotion practices, we see that several health issues are targeted simultaneously. Programs are tailored to address specific needs of the population. Outcomes are evaluated carefully. Change, please. Workplace health promotion programs, also called workplace wellness programs, include such as exercise, nutrition, smoking cessation, and stress management. Change, please. Physical activity programs reduce feelings of anxiety and depression, reduce obesity, reduce risk of chronic disease, and finally improve stamina, strength, and energy. Further, given that most adults spend half of their waking hours at the workplace, for individuals who might not otherwise participate in physical exercise training, the worksite setting offers a unique opportunity to promote physical activity and fitness. Change, please. Workplace-based physical exercise program is one of the important approaches to protect and promote workplace health and to reduce the risk of musculoskeletal disorders. Change, please. Workplace-based exercise programs for preventing work-related musculoskeletal disorders and injuries can be integrated work health promotion interventions. Change, please. The current recommendations for adults health promotion, a minimal dose of 150 minutes a week of moderate intensity aerobic activity, example endurance training, and change please. Muscle strengthening exercises 2 days a week. Change please. Physical demanding work appears to be trending increase the risk for long-term sickness absence, even after adjustment for relevant contributors such as leisure time, physical activity, alcohol intake, and smoking. Change please. In these conditions, well-planned, regular physical exercise habituation is one of the effective disease prevention behaviors in workplace. Change please. The effectiveness of the well-planned workplace exercise intervention result in reducing health risks, which include positive behavior changes, improving muscle endurance, muscle power, physical fitness and working conditions, reduction of waist circumference and blood pressure, and preventing work-related musculoskeletal disorders and accidents. Change please. It is important to develop appropriate workplace-based physical exercise interventions according to the individual differences of employees and characteristics of workplace to protect and promote both occupational health and health promotion. Change please. When planning a workplace exercise program to maintain health, attention should be paid to early musculoskeletal symptoms at specific risk groups. The planning of the exercise program is developed on assessed needs. For example, the exercise program should be planned to increase strength of the trunk and neck shoulder musculus for employees with low muscular strength of the trunk and neck shoulder region. The aim of this exercise program is to prevent cumulative trauma and musculoskeletal disorders and to preserve work ability. Change please. Physical exercise program should be designed to benefit and protect individual employees' health by addressing and preventing the root causes of occupational health disorders and injuries. Change please. It is a good opportunity to regularly include well-structured health-enhancing physical exercise into weekly routines at the workplace to counteract the negative side effects of monotonous physical tasks at work. Change please. In workplace exercise program, conventional exercise can be performed to warm up the muscles before starting work. Exercise tailored individually before each break is also required to prevent musculoskeletal disorders. This exercise is effective for softening muscles that are used repeatedly during work. Stretching is necessary after completion of work. Change please. The findings and outcomes of the workplace exercise program should be monitored and evaluated and shared to all stakeholders for feedbacks and improve of the program. Change, please. Applying health promotion and exercise programs at the work site together have positive health outcomes and also cost outcomes. Change, please. For example, exercise capable of improving physical fitness and strength can be integrated into the usual workflow of an industrial workplace with a minimal cost. Change, please. Workplace-based exercise program should be complemented by various health-promoting interventions focusing on individual, organizational, and environmental factors affecting employee health and require the combined effort of both employees and employers. This approach enables a strong integration of health promotion and occupational disease and accidents prevention. Change, please. In contrast, applying workplace-based exercise program within the scope of health promotion program by ignoring the occupational health factors may be insufficient to prevent occupational disease and injuries and to intervene in the early period. Change, please. Workplace-based physical exercise programs can be more likely to be successful if health promotion and occupational disease prevention together is considered in their design and practice. Change, please. Despite previous studies have reported the importance and effects of worksite-based exercise interventions, there is currently a lack of clarity regarding their effectiveness. So, well-designed new studies need to be conducted for finding high-level evidences and improving interventions. Change, please. Further research can be planned in order to contribute to the strong scientific evidences of workplace-based exercise programs in which occupational health and health promotion are considered together in terms of employees' health. There are a lot of factors for research and discuss on that affect workplace-based exercise programs. For example, team of exercise programs or assessment methods or evaluation approaches. Now we can talk about team. Please think on which professions should be in team for planning and applying the exercise programs. What do you think about the role of physiotherapists to integrate the workplace exercise programs into health promotion? Please change slide. Thank you. Musculoskeletal disorders are a very serious problem at the work site that have an effect on various organizations related to the industry, insurance, and health. They influence the economy negatively. So, prevention interventions bring medical and social and economic benefits for everyone. Ergonomic design of the workplace, a multidisciplinary program involving health and security arrangements of the employers are the most important to control the work-related disorders. Taking preventive measures save the employees from being disease and injuries. And regularly assessment and suitable programs include exercise should be continued. The new workers should be joined in this program only after being assessed about their pre-employed period. It is important to learn physical characteristics of the employee. The biomechanical and physical factors should be taken account as much as physio-social factors. Change, please. I try to give some research examples to explain the role of physiotherapists in workplace exercise program. This is another research. This research showed that the exercise programs capable of improving physical fitness and strength can be integrated into the usual workflow of industrial workplace. And change, please. And this is the last our research that I would like to show you. At the end of this research, we show that it is very important to give a place to the exercise which increase physical fitness and programs which increase consciousness by physiotherapists in the struggle against musculoskeletal disorders and health protection programs. And I wonder if do you have any question or comments, or would you like to share your knowledge and experience? Maybe I can see. Okay, I can't see any question on the chat, but we can continue our contact in the future. I will be very happy if you share your opinions and experience with me. You can send your message to my email address. And at the end of my presentation, I would like to thank you, the organizing committee, for inviting me to this conference. And I am very happy to be with you to share my experience and knowledge with you. I hope in the future we keep contact each others. Thank you very much for everything. Yeah, it's okay. Hello.
Dr. Is anyone having any questions? I think there are no questions, Dr. Freda. Thank you once again for your presence and presentation.
Thank you. I hope
So
we keep
presenter, Dr. Zelena Markovic-Filipovic from University of Novi Sad, Serbia. Hello, Dr. Zelena.
Hello to everyone.
Are you ready?
Can you give me the permission to share my screen?
Yes, yes. You are the presenter now.
Okay.
You can share your screen with us.
Okay. Do
Yes,
you see
it's
my?
visible.
Okay. Just. Okay. Good afternoon to everyone. First of all, I would like to thank to organizers for the opportunity to present today at Occupational Health Conference. The aim of my talk is to show you the effects of acrylamide exposure on inducible nitric oxide synthase expression in a liver. Acrylamide is a white crystalline solid substance. It is an important industrial chemical that has been available commercially since mid-50s years. It can be harmful to the eyes, skin, and nervous and reproductive system. The International Agency for Research of Cancer has evaluated acrylamide as probable cancerogen to humans. On the other hand, polyacrylamide is non-toxic polymer of acrylamide, and it has many applications in the industry. Some of applications of polyacrylamide is in paper packaging, dye synthesis, pesticide production. It is also used as the soil stabilizer, cement production. It is used in the textile industry, in the cosmetic industry, and as a flocculant for wastewater treatment. Although polyacrylamide is non-toxic, a photochemical reaction and high temperatures could induce releasing residual amounts of acrylamide monomer and thus contribute to the contamination. Example of workers who are at risk of being exposed to acrylamide are workers who manufacture certain cosmetics and toiletries, also employees exposed to certain types of dye and organic chemicals, manufacturing workers who make polyacrylamide, and construction workers involved in construction tunnels, wells, and sewers. According to the World Health Organization, at occupational exposure, repeated skin contact with acrylamide and its polymers present the greatest risk of poisoning. Proper working practices, measures, and hygiene, such as frequent laundry of work clothing and the contamination of surfaces with body contact if possible, are important in preventing excessive exposure. Skin and eye irritation would occur with acute exposures. Besides its application in industry, polyacrylamide is also used in molecular biology, where polyacrylamide gels are used for DNA and protein electrophoresis. Animal studies have shown that monometric form of acrylamide shows neurotoxicity, genotoxicity, carcinogenicity, and reproductive and developmental toxicity. It is widely accepted that acrylamide-induced toxicity induces oxidative stress in cells. Therefore, the aim of our study was to examine the effects of acrylamide in induction of nitric oxide inducing synthesis expression and its activity in the liver. In our experiment, we had in vivo study which was conducted on rats and in vitro study that was conducted on hepatoma cell line. In vivo studies, adult male blister rats that were aged 65 days at the beginning of the experiment were treated either with 25 milligrams per kilogram or 50 milligrams per kilogram body weight of acrylamide for 3 weeks. Then formalin fixed paraffin embedded liver was cut into 5 micrometer thick sections and it was immunostained with anti-inos antibody. The amount of anti-inos in immunostained sections was determined using ImageJ program, and we measure the optical density in immunolabeled ions, since the optical density is proportional to the concentration of the stain. In our in vitro studies, we used red hepatoma cell line, since the liver most is mainly composed of the parenchymal cells, hepatocytes. Red hepatoma cell line was treated with 5 millimolar acrylate that was IC20 concentration and 4.5 millimolar acrylate for 24 hours. The second concentration was IC50 concentration. The nitrate concentrations in the cell culture medium was measured and as the indicator of nitric oxide production according to the bridge reaction method, and the relative transcription of inducible nitric oxide synthesis gene was quantified using real-time PCR. In these slides are shown the results of our in vivo studies in immunohistochemically stained liver section in control animals, which are represented here. The iNOS immunoreactivity was observed in non-parenchymal liver cells. In animals treated with acrylate, besides expression of non-parenchymal liver cells, the iNOS expression was also observed in the cytoplasm of hepatocytes. Treatment induced dose-dependent increase in contribution of low positive, positive, high positive, and total positive cells, as well as optical density of the immunostained iNOS, and this increase was proved to be statistically significant for the group treated with higher concentration of acrylate, or the group treated with 50 milligrams per kilogram of acrylate. In this slide are shown the results of our in vitro study. As you can see, exposure to acrylamide caused significant concentration dependent increase of nitrate level and the expression of the inducible nitric oxide synthesis in red hepatoma cell line. Nitric oxide is a free radical that functions as a signaling molecule that is required for normal liver physiology, but nitric oxide has its role in the liver pathophysiology. High levels of the nitric oxide production in the liver can disturb normal redox status and can cause the disturbance of the hepatocyte function. Obtained results in this study indicate that acrylate, by inducing the expression of the inducible nitric oxide synthesis and by causing the oxidative stress in the liver, exerts potentially hepatotoxic effects. Thank you for your attention. Do you have any questions? Maybe.
Thank you, Dr. Zelena. It was a nice presentation. Is anyone having any questions? I think there are no questions from anyone. Thank you once again for your presence and presentation.
Okay, thank you.
So moving on to our next presentation is from Dr. M. Furqan, Hasanuddin University, Indonesia. Hello, Dr. Furqan. Are you ready with your presentation?
Yeah, I am ready now. Do you credit my sound?
Okay, I'm going to make you the presenter now.
Yeah. Yeah, let me to present my material. I will share my material first. Bagaimana?
Yes, you are the presenter now. You can share your screen and start your presentation. Yes, your screen is visible to us.
Do you see now? Can you see my material?
Yes.
Okay, thanks very much. Yeah. May I start now? May I start my presentation?
Yes, you can start your presentation.
Okay, right. In Indonesia, no, is night. So I would like to thank very much for everybody attending my presentation. The title of my presentation, Behavior Model of Occupational Contact Dermatitis Prevention on Pesticide Spraying Farmers in Goa Regency in Indonesia. According to my abstract published by a committee, the outline of my presentation, the first is objectives, method, result, conclusion, recommendation. But I think I need to give introduction first. Yeah. Farmers are the largest working group in Indonesia and use pesticides to increase their agricultural yields. Pesticide spraying farmers have a high incidence and risk of occupational exposure to pesticides such as occupational contact dermatitis. The question, how is the behavior of farmers for pesticide to prevent occupational contact dermatitis in Indonesia? The general objective of this study to find out the behavior model of occupational contact dermatitis prevention on pesticide spraying farmers in Goa Regency in Indonesia. This Goa Regency located in South Sulawesi, the middle part of Indonesia. Specific objectives to determine the effect of modifying factors, age, gender, occupational dermatitis contact, history, education, income, and knowledge on behavioral belief, attitude, normative belief, encouragement, control belief, self and environment, intention, and practice in preventing occupational dermatitis contact. To determine the effect of behavioral belief, attitude, on intention and practices in preventing occupational dermatitis contact. To determine the effect of normative belief, encouragement, on intention and practices in preventing occupational dermatitis contact. To determine the effect of control belief, self, on intention and practices in preventing occupational dermatitis contact. To determine the effect of control belief, environment, on intention and practices in preventing occupational dermatitis contact. To determine the effect of intention on practices in preventing occupational dermatitis contact. Food objectives is to determine the effect of control belief on intention and practices in preventing occupational dermatitis contact. To determine the effect of control belief on intention and practices in preventing occupational dermatitis contact. The last, determine the effect of intention on practices in preventing occupational contact. I display the conceptual framework of the study like this. Yeah, actually, I adopted from the behavioral health model and blended behavioral behavior. Yeah, I modify factors. Yeah. And then behavioral belief, normative belief, and control belief. How the modifying factor affect behavioral belief, normative belief, and control belief? Now, how modifying factor affect intention and behavior? All variables here will be tested to evaluate their significance each other. Method, yeah. Cross-sectional design, location, duplex of vegetable garden in village of Patapang district of Tigimoncong, Regency of Goa, Indonesia. Population of farmers in this area, 150 people divided into 5 farmer groups. I take more than 10% as sample. Totally 97 by using methods to find random sampling. This is the result, demographic characteristic of the respondents. Yeah. Commonly male, 95%. They have high education. (64.6). History with occupational contact dermatitis. Yes. Yeah. 62 people or 64.6%. Knowledge about dermatitis contact prevention commonly low, around 72.2%. This is statistical testing. We can see here some behavioral, some variables, but significant values, and some non. Yeah. Belief factor, behavioral belief, attitude. P 0.0. Modifying factor, intention, 0.907, not significant. Modifying factor and practices, not significant. The value is 0.8 to 8. Control belief, 2 practices, not significant. So we can see here the variables have some significant and some not. This is multivariate analysis. I have difficult to read it because so small. Yeah, but we can see the result here. Yeah. Yeah. According to the study data, I can see modifying factor to behavioral belief, attitude, P 0.0. Yeah. And we can see here modifying factors affected pesticides prime farmers in preventing occupational contact dermatitis, but modifying factor to intention and practice didn't affect pesticides prime farmer in preventing occupational dermatitis, contact dermatitis. Yeah. Behavioral belief to intention and to practice effective pesticide spraying farmers. Conclusion, modifying factor to the behavioral belief, attitude, the normative belief, encouragement, and the control belief, self and environment, affected pesticide spraying farmers in preventing personal contact dermatitis. Modifying factors to the intention and the practice didn't affect pesticide spraying farmers in preventing occupational dermatitis contact. Behavioral belief to the intention and the practices affected pesticide spraying farmers in preventing occupational dermatitis contact. Normative belief to the intention affected pesticide spraying farmers. But normative belief to the practice didn't affect the pesticide spraying farmers. Same with normative belief encouragement to practice didn't affect the pesticide spraying too. Control belief affected the intention, but it didn't affect the practice of pesticide spraying farmers. Control belief environment affected the intention and the practices of pesticide spraying farmers. behavioral belief, and control belief environment were the most effect on the prevention behavior of pesticide spraying farmers. So we can use this is the last conclusion to make new model to improve the prevention behavior of pesticide spraying in Indonesia. Recommendation: pesticide spraying farmers practicing occupational dermatitis content prevention by improving the environment of control belief, especially providing body sanitation kit, not only hand, to the whole body. Practice occupational dermatitis contact prevention by improving the attitude of behavioral belief, especially not touching pesticide residue without using gloves. Recommendation for government, local government, pay attention on modifying factors by educating pesticide spraying farmers regarding knowledge and practice on occupational dermatitis contact prevention. Pay attention to the environment of control belief, especially providing hand washing facility and clean water. Food research are needed to test an intervention behavioral model resulting from this study and perform the standard operational procedure to prevent occupational dermatitis contact in Patapang village, Goreges, location of this study. This is the end of my presentation. Thank you very much for your attention.
Thank you, Dr. Furkan, for your presentation. Is anyone having any questions?
Yes, I have a question.
Okay, please
Yes,
proceed
please.
with your question.
Thank you. Thank you, Dr. Furkan, for your very nice presentation. I have just an easy question. Did you also study the interaction between pesticide use and heat stress that represent an important environmental factor to which workers are exposed, and I think especially in Indonesia?
Yeah, pesticide and stress. What do you mean?
Yes. Yeah, the interaction between pesticide use and heat stress condition, environmental heat stress.
Oh, not yet, not yet. Yeah. But I want to improve my research about this perception to perform educating among farmers, because in Indonesia, yeah, a lot of farmers suffering from dermatitis contact and other bad impact due to exposure to pesticide. I think the most important here, how to educate farmers. So I did this study actually to have model which variable I can modify or focus in order I can perform good education for farmers. Thank you.
Thank you very much.
Thank you. Is anyone having any questions? Okay, thank you once again, Dr. Furkan, for your presence and your presentation. So our next
Thank you.
presenter is Dr. Momoko Zamami from University of Liverpool, UK. Hello, Dr. Momoko. Are you ready with your presentation?
Yes, can you hear me? Okay.
Yes, yes.
Okay.
I'm going to make you the presenter.
Sure.
Yes, you are the presenter now. You can share your screen with us and start your presentation.
Sure. Actually,
Yes, your screen is visible to us.
okay. Yeah. You can just call me Momoko. I'm not doctor, but I
Okay.
am. Yeah. Sorry, that's okay. I'm Momoko, and I'm a project administrator at the Queen Mary University of London. And I'll be talking about the research done on work stress and the impact on health and well-being in science and technology sectors. And this was part of the MPH dissertation done at University of Liverpool, specialized in management of health systems, advised by Dr. Hochmeister. And the research was conducted during the period of January through July 2019. And all the research work had been completed before the COVID-19 pandemic emerged. And starting off with the definition of what is work stress or work-related stress or occupational stress. There are many different ways that this can be explained. And one definition by health and safety executive says, adverse reaction people have to undo pressures and demands placed on them at work. And it is important to note that when you're discussing work stress, there are two main components to this, which are sources of stress, a stressor or what causes stress, and the other one is stress responses or how you respond to stressful situations. And for evidence or statistics of work stress, in the year 2019 through 2020, there were 1.6 million cases reported in the UK of work-related ill health, and this is equivalent to 32.5 million working days lost of the workers, of which 55% or more than half were due to stress, depression, or anxiety. And it costs approximately £10.6 billion per year for the incidence of work-related ill health, excluding injuries and long latency illnesses. Even though the numbers of work-related injuries have fallen in the recent decades, the numbers of work stress have been increasing, and it's been more than doubled since 2010. And there are various factors that might be attributed to this, and partially due to change in the working environment or working conditions, along with information technology system, digital communication, administrative compliance, data protection, cybersecurity issues, global e-commerce, which makes the workplace more complex and competitive and puts workers more vulnerable to stress. Additionally, we're becoming more aware of work stress than we were before in the past. And we're also starting to report more than we did in the before. And according to the data sources available, during the COVID-19 pandemic, a lot of things happened in the workplace, especially among healthcare workers and essential workers, impacting their mental health and some of them leading to burnout. And it'll be important to understand what happened during challenging times. For the health profile, workers who report work stress have higher risks of cardiovascular diseases, mental health issues, depression, self-harm, work-related injuries and accidents. And there are health inequalities, especially in the regions where they have ethnic minority population and among migrant populations. For life expectancy at birth, mortality rate under 75, for cardiovascular diseases, cancer, mental illnesses, drug use, and self-harm. And in the region of Southeast England, this region has the largest population in the UK, has a highest gross domestic expenditure on research and development of £6.73 in 2017. And this means that there's a lot of investment being made in this region for science and technology, innovation, a lot of work being done. This is for sustainable future economy, sustainable energy sources, along with climate change and global economy. And for legislation for occupational health and safety, there are many laws in place. And these are just examples, including management guidelines for risk factors for work-related stress. And based on the facts and evidence, a research question was developed to explore the perceptions of high-skilled migrant workers in science and technology sectors in Southeast England on work stress and the impact on health and well-being. And this was approved by the Ethics Committee, and the local ethics guideline was followed. Literature review was conducted, and this is to identify and fill a gap in the literature and other research conducted. For the method, qualitative research was conducted with an interpretivist approach, with the semi-structured interviews with 10 participants from 8 countries around the world, representing a wide range of science and technology occupations, including biological science, computer science, IT, material science, medical science, healthcare, and social science. This was a small-scale study, and for data analysis, thematic content analysis was conducted. And this was a human participant research, and I like to point out that ethical consideration have been followed throughout the process. This is ensure that the members were comfortable, they're well, and they're well supported throughout the process. And this also helps to mitigate potential sources of bias. And for findings, there were 3 main themes and sub-themes have been identified. Perceived causes of stress. All participants felt that work demands were the major sources of stress, including tight deadlines, heavy workloads, long working hours, job insecurity was mentioned, and not understanding clear roles and responsibilities of the job, and not having voice in the organization, and not having a mobility within the organization were part of the responses. Technology and stress. These participants are scientists and some are health professionals, and they had both positive and negative perspectives on this, even though their work relies on science and technology innovation. On one hand, technology improved their work tremendously with advancement in technology, speed and accuracy, and efficiency. On the other hand, information communication technologies such as email, instant text and messaging, social media, and this could be distracting and disruptive. And additionally, technology changes rapidly. And if you don't understand well, and if you don't keep up with the speed or the pace or the trend of technology, this could be a disadvantage and potentially could lead to stress responses. Impact on health and well-being. All participants thought that stress could lead to negative impact on health and well-being, physiologically, emotionally, psychosocially, and relationship with other people, and work performance and quality of life as well. Short-term stress, this could actually motivate people to achieve something or deliver something for goal attainment. At the same time, it is essential to manage and cope with stress during this short-term period. If you don't manage to do so, this could lead to prolonged stress, long-term stress, and even chronic stress. This is when you start seeing a negative impact. Some of the responses included the changes in health behavior, such as change in eating habits, sleep patterns, and start losing interest and motivation at work, drug and alcohol use, impacting mental health, and leading to some of the illnesses in the long run. Work-life balance, this was something that majority of the participants felt difficult to achieve. And those who had a family and care responsibilities, they tend to set the boundaries so that they can maintain a good balance between work and life. And they could switch off when they need to. And for coping mechanisms, support system was mentioned by all participants. And this included having trusting relationships with family and friends and colleagues, and having a supportive environment and culture in the organization would be a key source of coping mechanism. And for mediators and barriers, this varied by individual worker. Mediators included using technology such as social media platforms were mentioned, effective communication in the organization, and having access to resources and support, and also doing some exercise was mentioned. And for barriers, so this included policy implications, lack of support and access to resources, and structural barriers also mentioned. And for those who are from non-English speaking countries, they thought that cultural and language barriers could be also an issue and could lead to stress responses. In conclusion, problem-focused coping was discussed, particularly by some of the participants during short-term stress. This is to identify the problems and trying to mediate stressful situations by communicating with the supervisor, colleagues, and trying to adjust to workloads, working hours to make it more flexible and sustainable working. And emotion-focused coping, this was applied by all participants. And this included mindfulness, meditation, going to the gym, doing yoga, and having positive attitude, and having positive outlook in life, and having life outside of work, and having activities outside of work, what mentioned, and having that relationship with family and friends and colleagues that you feel safe and you can trust seems to be the key source of coping mechanism. And I like to highlight that there are individual differences in how each worker perceives and internalizes stressful situations. And these coping mechanisms were applied by these workers that they felt that was available to them and accessible, and that was feasible, suitable, and appropriate, depending on the situations they're in. And finally, I'd like to mention that it is crucial to find a good balance between work and life that is sensible to each worker. And for discussion, I would like to bring up the theme of this conference, which is the public awareness and responsibilities regarding health and safety issues. And based on the findings from the research, the three key elements were addressed. policy into practice. This is to better understand these guidelines and policy in place and trying to put into practice sensibly and adequately. And this can be enhanced at the organizational and societal levels and addressing the needs of the workers. This is to better understand the perspectives of the workers and what they're going through. Some of the participants mentioned having tea breaks and coffee breaks and communicate with the workers. And this can be strengthened at the organizational level. And finding a good balance, because each worker understands what might work best for them. And this also relates to help-seeking behavior. It's important to find a good balance, and if they need help or support, it's important to be able to seek for help as needed. And the diagram on the left-hand side, this illustrates wider determinants of health. To explain that, it takes collaborative effort at all levels of involvement by all stakeholders to make things work and make things better, to try to mitigate work-related stress and help protect health and safety and well-being of the workers in our society. And for future research, it would be helpful to understand perspectives of other stakeholders. Examples would be employers from different regions, backgrounds, and other industries. And during the COVID-19 pandemic, a lot of things happened around the world to both employers and employees. And it would be helpful to understand what happened and what the experiences might have been, especially among healthcare workers and essential workers and frontline workers. And other methods and larger sample size will be helpful to make the findings more robust and concrete. And I like to acknowledge all the members who took part in this study and the members of the Occupational Health and Public Safety Conference, and Nicholas for the support. So thanks so much for listening, and I am open for comments or questions, if any. Thank you very much.
Thank you, Ms. Momoko, for your presentation. Is anyone having any questions?
Thank you.
Yes, I have one. Is it possible?
Sure.
Thank you, Dr. Momoko, for the presentation, which I found very interesting and useful.
Thank you.
And I understand that you have done a deep review on work stress.
Mm-hmm.
And did you make also a special service, for example, by questionnaire submission to evaluate work stress perception in the UK? And the second question is, which solutions against work stress especially addressed to protect ethnic minorities?
Sure, thanks so much for your question, Marco. So the first question regards to asking about questionnaires or surveys. So yes, it's part of the qualitative research, and I used a methodology by using a semi-structured interviews. But the question was just initial interviews based on a topic guide and interview guide. And I piloted the study, and there were certain general questions initially to pilot. Then I amended, adjusted some of the questionnaires based on the prompting and also probing questions and the feedback that I received from the volunteers. But to answer the question, no, this was not a questionnaire or survey. This was in-depth interviews, face-to-face, semi-structured. And I did have a follow-up with the participants, but no further data collection has been done. And secondly, in terms of what you to be recommended for the interventions for the ethnic minority for mitigating stressful situations, I think I highlighted that there are individual differences, and these participants were migrant workers in the UK, and they were from outside of the UK. They were not born or they were not British citizens at all. And each of them represented 8 countries around the world, but they had a very different perspectives. But to tailor the culture was very much of the context that I gather, because the cultural and language barrier seems to be a very much an issue among these highly skilled migrant workers, even though they're very much qualified. The day-to-day practice and trying to integrate into workplace. And I think lastly, just what works best for them. So mindfulness was mentioned by a lot of people, and having the support networks with other people, colleagues, that you feel safe, and even other workers from their own countries. That was mentioned by people. But personally, I feel that there's a certain strategy that works for each worker at the individual level. So whichever works best for you. It doesn't have to be one method, but could be multiple. And that's something that I notice. That's culturally tailored approach would be very helpful, I think. I hope that answered your question.
Perfect. Thank you.
Thank you so much.
Thank you, Ms. Momojo. Is anyone else having any questions? Okay, thank you once again for your presence and presentation.
Thank you.
So as we are running ahead of our schedule, so I would request Dr. MD Sultan Mahmood from Japan Advanced Institute of Science and Technology from Japan to present his speech now. Hello, Dr. Mahmood. Are you ready with your presentation?
Yes, can you hear me?
Yes. So I'm going to
Okay,
make you the presenter.
okay.
Okay.
Sure, you can give me the scope, no problem at all.
Yes, you are the presenter now. You can share your screen with us and start presentation.
Can you see my screen?
Yes.
Okay, well.
Yes, it's you can start your presentation.
Thank you very much. Well, I will start just. I want to just move the. Now the screen is okay for everyone.
Yes, perfect.
Thank you. So, well, hello everyone. This is Sultan Mahmood from Japan Advanced Institute of Science and Technology. I would like to present my recently published work. Based on that, just I submitted one more paper on this occupational health safety. But this is more about the management related research, and the topic is on workplace health safety towards sustainability in the labor intensive industry, usually garments sector we focused. So here are the contents to be discussed. Like conventionally, we start with the introduction, research aim and question, this is methodology, data analysis, findings, discussion, and conclusion limitation. So, well, we start with the introduction chapter. Just give a brief details about the workplace health safety. Actually, the WHS means workplace health safety issues become. Actually, this issue become very serious agenda in global garments production since 2013. Why 2013? Usually, there were two biggest workplace accident, very consecutively. One in 2012, Tazrin fire in Bangladesh garment sector, and another is Rana Plaza building collapse, which is very much highlighted in all over the world in the global supply chain. A total of 112 workers died in 2012, and 1100, above 1100 died in 2013. Actually, I say it's killed, not died. However, more than 2,500 were injured because of this historic disaster. This accident actually revealed the inhumane work condition throughout the global fashion supply chain as well as in the producer side. Because of rapidly increasing the fashion appetite kills the worker over the decade. So if we're looking back the history, the workplace disaster is not new in the garment sector. There is a lot of incidents, and even Bangladesh, a lot of the global garments production network, a lot of accidents happened already. The Rana Plaza Tazrin and similarly in 2012 there is Ali Enterprise in Pakistan also actually recalling the same memory like century back Oats industrial mishap of the Triangulist Shirtwaist factory in Lower Manhattan, New York. Usually in Bangladesh, a lot of foreign reputed global brand like H&M's, Zara, C&A, such big name are working in Bangladesh, and they produce their product in the garments factories, and their intervention is very high. So most responsibility actually goes to them, and their supply chain strategy also criticized long over the time because of this their approach to outsourcing, and that incentivize actually the workplace accident, many more accidents. So here you see some picture. In the left side start with Rana Plaza 2013, the building, and the Tazrin, you see this everything is burned. And these are the rightmost is a triangulist fire 1911 in the Lower Manhattan. See there's the glimpse of death in over 1100 in Rana Plaza, Tazrin already I told, and Triangle Factory also 140 people died on that back 19th century. So here are some glimpse of this garment sector of Bangladesh. You see the export is increasing since it's 19 less than 1 billion, but in 2018-19 our last data collection which we actually recorded here is 34 billion. It's sharply decreasing, almost every decade is decreasing. And there is a percentage to the export share. It's mostly in Bangladesh, export is come over 80% nowadays in the total export from the garment sector. It's almost 16% GDP in our country, and it is the second largest garment maker since 2010, which sharing 6.5% in all over the in the world market. So these are actually the positive side of this sector, and these are the employment. This sector also create a lot of employments. It started 384 factories since 1985, 84, 85, when only 120,000 people on the time working, and now after till 2011, 12, 2012 and 13, it is factory is increasing, and also 4.5 million, almost 45,000 100,000 people, 4.5 million people until 12 and 13. It is increasing number of people employment, but after that sharply some decreases because of some accidents, because many people actually leave migrated from this sector to another sector, and also some factory become closed because of many issues. And this sector is almost 70% migrated women come from the rural area working. Actually, the number is still controversy. Many research has shown below 70. Many research has shown more than 80. So, however, we gather the data from the BEZAB, like the Bangladesh Garments Exporter Association. So, they are, according to them, 70% people, or 70% representing women. However, the garments sector actually play a critical role in both in considering national economic growth, as well as it's also a potential obstacle in the future development. Some research also shows this. Mainly the deadly Rana Plaza accident and Tazrin fire, these accidents reveal the inside working scenario of the garment sector. And many buyers also criticize, as I told, and therefore the supply chain. So, however, after this accident, there are two private regulators who we say that safety administrator, two safety administrator, and one is the government and two from buyer side. Accord, this name Accord is from European brand and Airlines from American brand. So these all both regulators actually back up by global brand, trade union, and international law authorities. So after their intervention, so the sector has go under several inspection and remediation, and they force every factory, as I show you that almost 5,000 factories in Bangladesh working for export garments. So these are the figure has shown in the inner circle is the number of factory by three regulator. One is the Accord, Alliance, and National Action Plan. So it's a government. So Accord is actually covered above 1,600 factories, and National Plan covered almost 1,500 factories. So which considering like Accord like covered like 2.2 million people, and government action also like covered almost 1.5 million people. Another is Alliance from the North American buyers and as well as their trade union. They supported, and also it also like 1.3 million workers. They covered almost 672 factories they inspected. So a total of from their result and their data we analyzed from the public available data we gather from this all three regulatory website, and we found that like a total of 30% factory have finished almost 80% repair work. Only 30% factories of all three completed 80% repair work, and only 2% factory actually terminated due to which is very vulnerable and unsafe working condition. So these are the research aim. So the importance actually, the motivation comes from this research actually from the workplace safety. Why actually this is workplace, the importance of workplace health safety management, how actually Bangladesh government's factories nowadays they improve their condition. So the broad aim of this study actually workplace health safety issue of labor intensive garment sector to explore their approaches, how they handle the factories. So that's why three more subsidiary research question on this main aim we want to achieve, like what operative challenges force garment supplier to overcome workplace health safety challenges, and what are the key measures taken by the garment sector to implement or improve the health safety compliance, and how to model a health safety compliance for R&D sector to sustain the market competition. So these three actually led the major research question, how effective the workplace health safety compliance. So these are the research methodology. We just give a overview to understand. And three part actually, this is a qualitative study completely, and also with some quantitative data, which we use some descriptive statistics, and the qualitative analysis we usually using like three main steps: data collection, employing the methodological triangulation. And analysis goes through like summarizing and simplifying all data, and data come from like as we say methodological triangulation. So interview, it's in that interview, and observation and document. We actually direct observation we follow here, and document review. We collected public and internal documents in our case. And then we develop the code data level based on the meaning and further identify pattern. So based on the relationship, then we create some categories. So in these three stages, we say that the lower stage is data from the raw data. Then we create information, and this information give it knowledge to. And finally, the interpretation comes like describing the phenomena, facts, and their patterns relationship to generalize and construct the new meaning. Here we purposely select 3 case study, and the respondent also selected purposely 12 respondents we selected based on their related knowledge, relevant knowledge. So these are the case selection criteria. Actually, 3 firms assemble similar product. We focus actually similar product manufacturer, so then we can easily justify the approaches among them. What are the barrier or variety or some similarities? And second is a lead supplier. They are the direct supplier. I mean, then lead supplier as well as direct supplier to the Western clothing brand, and registered member of the Bangladesh Garments Manufacturer as well as Bangladesh Knitwear Manufacturing Association, as well as they listed also the Accord Alliance member, so they are approved by the Accord Alliance. Finally, the all case manufacturers are accredited by BSCI, like Business Social Compliance Initiative, and SADC. These are the social compliance requirement, audit requirement. So we usually use select 3 case because it's as a multi-case strategy we actually apply here to select the garment supplier from Bangladesh because of the greater visibility and replicability among the cases. And also it helped to give us a broader exploration of the research question and theoretical explanation, multi-case strategy, and give the conclusion obtained from the multi-cases become more potent than a single case. That's why I selected 3 cases. So these are the case analysis. If we go through some 3 firms and their employee size, like you see the 5,000 is the first, and second one is almost double employee, and firm C also like 5,600 people. And the annual turnover also, they have a sizable annual turnover, or A and C like less than like 60 or around 60, and but firm B is 130 million USD. And these are the major customers. These all are known customer, and they have also social compliance certificate, as well as they are also joined workplace safety program by the private regulator. And these are the admission date of with this regulator. And in the below figure 1, it has shown the employee size by the number, and male and female. Both A and B actually male dominated manufacturing, and C is female are more in their workforce. So however, as Bangladesh is already known that 70% women are participated in garment sector, but in our 2 case actually it say that both are male dominated. However, the employee percentage is shown in the figure 2. It has shown that like 62% by and 62% by farm A and 64% by farm B male dominated, and only farm C 55.59% are women. So here the economic importance of these 2 firms, because they, I already told, they have like their annual turnover is increasing. Like say last 3 years we find the data from their profile and their internal document that sharply, not sharply, like steadily, like farm A, B, C, all are steadily improving, and as well as their annual sales, like in USD, and also the say like million pieces, like in the blue column shows the value in sales, and green column shows the dark green column shows the production pieces, like how many pieces they ship and against how much dollar they income. So mostly it has shown that the B is above like $120 million in last 3 years in a row, and other 2 is less than like 60. Just only B, A in 2018 and 19, there's $62 million with in regard to their production is 26 million pieces. However, the annual growth is shown that farm A is 11% and also C is like 10% in the 2018-19. But however, C farm B is decreasing the growth in 2018-19 from the previous, considering the previous year. So these are the workplace status of these 3 firms. You see that the construction risks, actually 3 risks we usually identify in a broaderly by private regulator and public regulator. The structural, fire, and electrical. These are the property or their construction. So based on the 3 risks. So in the structural risks, like farm A is like more higher than the other 2 farm, and also but considering fire, farm B is found more risks observed in farm B. In case for the electrical, farm C is observed higher risks. However, these 3 farm already remediate, like a C already remediate 100%, almost remediated, and other 2 farm above 90%. The total duration of the remediation almost take like 5 years for all 3 cases, above 5 years for C and A. So these are some voluntary code of practice we found for all 3 cases, like on-site medical center for improving the occupational health to support their employees. Also, they recruited professional occupational nurses, full-time occupational physician, outdoor medical facility. Also, 3 farm introduced, but still we found that A and C is not available, the first aid box for all 4 floor. They have like building, each production building, they have one for each production building, not floor wise. So mostly actually first aid box is most important because of every production assembling line, there is a number of people working sewing machine. They have a very frequent some cut and machine own. This is very common, but farm B actually incorporated for each floor. They have a one specific area for first aid, and child care facility for all farm has introduced child care facility, and health checkup for new employee for all 3 farm. They also incorporate this policy. Annual medical camp only C. Every year they have a one medical camp, and they will go through screen all employees health, but B and A still not introduced these facilities. So reproductive healthcare for women also only B introduced, but other 2 farm not. Annual eye care also only C, other 2 farm not. And mental health and stress awareness only from B initiated this. So considering actually among the 3 farm, based on their understanding, based on their resource capability and management perception, these are some voluntary code of practice are varying. So here are the main tasks they actually do for done by workplace initiative. First is physical environment safety, second like occupational health, and third in worker rights. So in physical environment safety, they actually structural, electrical, and fire safety inspection and remediation. They focus mainly 3 areas for the factory construction, and they're developing the chemical regulation and increase the use of personal protective equipment, and promoting the employee awareness through safety training, worker participation, and monitoring mechanism. As well as one more initiative, the periodical inspection by the independent auditor, such as the third-party audit or buyer social audits. However, this physical environment safety, actually the guidelines or the standard, they follow the regulatory measures and voluntary codes like National Building Codes of Bangladesh 2006, the National and National Fire Protection Act, and Labor Act, and labor rules. Actually, the all regulatory guidelines come from these laws and rules. And in considering structural implementation, actually Accord on Fire and Building Safety, Alliance Accord, and National tripartite plan of action actually help this farm, as well as the factory internal, also factory safety engineers and safety officers also involved to implement these physical environment safety issues. And concerning the occupational health, they devise health and hygiene measures to improve workroom temperature, visibility, air quality, and we found also they use like the cooling pad in the window, and they reduce the assembling line and to improve the confined space because of the health hygiene measure. They took this And also they emphasize location-based and work-based hazard, because the two type of hazard they actually source, they consider location and work-based hazard, and adopting primary healthcare practices by integrating internal medical center, recruiting nurses and physicians, and preventing measure for workers regular illness and disease control. They have the medication, the doctors and the nurses usually provide the medication and prescription for regular some regular drug they propose to the workers for general health issues. But if any other like severe condition, they actually recommend to the local hospital. They have some like pharmacy has two local hospital collaboration. Farm A also has one big hospital, public hospital collaboration, and but Farm B we don't have see any collaboration with any hospital. So, however, in that case they follow the regulatory measure like National Occupational Health Safety Regulation and level law, also level law 2006 in Bangladesh last, which is issued, and rules 2015 they actually take as a guideline from this, as well as also some standardized framework, global standards framework like ISO 45001 is a like we call say like occupational health safety standards through international standard organization, and some other also from Ocotex, BSCI and SADC has some provision for the occupational health. And in that case the implementation actually external auditor and state monitoring mechanism, they actually monitor regarding these issues, and factory compliance team, internal team like factory compliance, health safety officer and sustainability team actually taking care of these issues and to implement these issues or review and analysis if they need any amendment or they need any changes in this area. And the worker right is another thing, like for occupational health safety, actually nowadays many literature also reveal that not only occupational safety or occupational health is improving the workplace health safety. Moreover, the worker rights is very important because many factories, or we see like in the global garment sector, the rights because of the many human rights and labor code practice are disregarding or absence in the production factory. That's why occupational health safety issues is degrading. So these three factory also focus like based on the human right and labor code practices, focusing the buyer COC like buyer code of conduct and national laws, and addressing ethical and social compliance issues like nowadays ethical issues for the ethical business practice, like they reduce overtime, they reduce like adjust the holiday duties. In earlier these issues actually very problem like absence, ignored by the factory people. Nowadays is manufacturer and the authority is started to focus on this ethical issue and social compliance issue. However, they also nowadays promote the worker association and union participation and management-based committee, labor management-based committee, and developing impartial and fair worker compliance management. Nowadays also they devise like some worker compliance management, which worker can report their any issues hiding their name. So they also arrange this kind of facility so that they can directly contact by management can directly contact with the worker through the this mechanism. So here also the regulatory measure actually they follow from the national level laws, rules and global standards framework like ILO Core Convention, BSC and SADC. In that case, like implementation is also some is like state monitoring and external audit. Because of the worker right issue also they have periodical audits by the third party, and factory compliance and HR team, welfare officer and sustainability team are working for managing the worker compliant issue and other worker right issue to monitor, and if any changes required, then they will actually follow the disciplinary action. And these are the discussions. So if we see the workplace safety mechanism of this three factory, actually why they actually started the workplace health safety consider. Actually, one is the two main issues, the operative challenges. In operation, they face challenges to work with the global buyers when after Rana Plaza accident. So some internal issue and some external issue. Internal issue like the production pressure is increasing, and as well as like financial pressure and productivity decrease because of the after Rana Plaza. This issue is rising internally, and external pressure like when shipment pressure is increasing because of the buyer thinking that the factory like new administrative changes will come would come, so they are pushing the factories to ship early as possible. So this also create the production pressure, and this shipment pressure also pressure for initiative like workplace health safety, because at the same time they push for shipment, at the same time they push for workplace health safety issue to confirm, because buyer compliance or audit division always force factory or push factory to improve. So however, this external another main factor is actually increased cost of the compliance cost of the, this is the challenges for the factory mostly, the increased compliance cost, which is influence also like these influences like customer, investor and industry association. There is some direct collaboration also required for managing this cost, and as well as like this stakeholder also mediated to like overcome their challenges. Some internal issues help, like when they join the legal body of inspection or remediation program, and secondly they increase social and environmental upgradation to overcome these challenges, and partnership with the indirect stakeholder like NGOs, INGOs, unions. However, externally they support like initiated safety structural electricity and fire safety assessment, as well as develop better this help to them better workplace culture, adopting new laws. So here is actually better workplace also motivated customer to improve their water, and as well as collaboration of the direct supplier also mediated like the partnership, and also facilitated to overcome the challenges to improve the workplace health safety issues. And these are the actually 4 areas we can identify, the 4 categories, the workplace health safety issues. 4 major pillar we identify from the suppliers, they usually improve. First is the physical space, like plant setting, workroom structure, and assembling line. Under this physical space, there's some subcategory like the plant setting, as I told. And in the physiological space, some subcategory like the worker, supervisor, and floor manager health condition. So, and cognitive space, supplier working for the mental understanding, like mental like stress or management or between worker and co-worker, and supervisors and line managers, like how actually manager deal with the line chief, or the line chief handle the supervisors, or supervisors handle co-worker. So this is the actually mental understanding about among all of them. So these are also considered by the factories to improve their mental health, and also the cultural stress. This also is very important, because they respect the diversity and cross-cultural understanding, and improve the personal communication and greeting system. Nowadays, actually, many health is not only just like biological, also some cultural issue. So manufacturer like develop some, as I show you, there's some mental our one case from already, they started counseling with the worker in the mental health issues. So that's why they focus on the worker worker diversity, worker cross culture, because even Bangladesh, from different part of the people are working, mostly from the remote area, so they are actually try to understand the people values and their morality to improve their health, mental health. So here are the 4D framework. We actually propose a 4D framework for any garments sector. They can actually follow this framework. So we can actually abstract this framework from our case manufacturing. Like first, they define the workplace issues as a business agenda. It means must be to consider the workplace health safety issue. Our proposition is firstly address the workplace issue as a business agenda. It should be a business agenda. When the owner or the factory management can realize this is actually a business agenda, if they cannot improve the health safety issue, they cannot improve the business, they have to face a lot of obstacle in business. So this kind of intention is very important. So that's why they have to define their business agenda and develop the policy and objectives towards the health compliance. So after that, they need to design the policy, what they plan, what kind of objectives department wise as well as team wise objectives they have to set, and then they have to collaborate with the policy and private regulators, such as like in nowadays public and private collaboration. Auditor are working, and some regulators voluntarily help the garment sector as well as, but the government and like introduced RNG Sustainability Council, RGS. So this government initiative also focus now, make a regular dialogue with the suppliers, and finally disclose their report, health, publish the inspection result and remediation status to stakeholder. So most of the cases still, like when the regulator Accord and Alliance started, they did the inspection, they publicly publish all data just in their website. But nowadays, mostly the factory, usually they don't publish their data in their website or their profile. They keep it actually like hidden. So this is the transparency issues and factory accountability issues. So we propose actually what improvement a factory have done, they should disclose so that the stakeholder can help to them. So here the conclusion and limitation. The actually health safety matter, as I told, is very important business agenda for global garment sector since 2013. After Rana Plaza accident, the accident actually became a wake-up call to develop the resilient factory infrastructure and health hygiene provision for improving compliance, health safety compliance. And the safe and healthy workplace help the garment supplier to develop preventive environment for workplace accident and occupational injury. Moreover, it also benefited to build the trust and with the customer and indirect stakeholder. So it's not only just improve internal environment or business, it also create trust and build the new images for the factories. But however, we have measured some limitation of this work. It also helps us to create the new future studies. The major limitation of this study is to consider the direct supplier. Actually, we focus on the just direct supplier and only similar category, product category supplier. We don't consider the heterogeneous factor here. So maybe there are some differences will come for the others heterogeneity, like so those are oven supplier or the denim supplier we don't consider. And also we don't consider here the subcontract factories for these studies. However, in Bangladesh, according to the New York Stern report, that half of the garment sector factories are subcontract. They don't directly ship to the buyer. As these are the quite large with sizable employees. We believe that in our study, the 3 sample, like which the 3 case also have a large some like employees and a large factory. So we believe that this result can be generalized and replicable in the future studies also. So that's all from our side. So from my side, and we have also like publication on this. Recently, we have publication for this issues just last March in a Scopus Index journal. So thanks to everyone. So if you have any question, you can ask.
Thank you, Dr. Mohammed Sultan, for your presentation. Is anyone having any questions? Okay, no questions, I think. Thank you once again for your presence and presentation.
Well, thank you very much.
Okay, so now we can take a lunch break and we'll be back at 14:30.
Well,
Yes, please stay connected.
thank you.
Thank you.
Thank you very much.
Yeah, hello everyone.
Hello.
Yeah,
Hello.
thank you for staying connected with us. Yeah, moving on to our next presenter. It's from Dr. Marco Morabito from National Research Council, Italy. Hello, Dr. Marco. Are you ready with your presentation?
Yes, I'm ready.
Okay, I'm going to make you the presenter.
Yeah.
Yes, you are
Thank
now
you.
the presenter. You can share your screen with us.
Yep. Can I be enabled?
No, it's not visible to us.
Yeah, I know, but I am not enabled by you to
Okay.
upload the presentation.
No, yes, I have enabled you. Now you are the presenter. You can share your screen.
No, it's not
Oh,
possible from here.
okay, just a minute.
Yeah.
Okay. Yes. Please check now.
Yes. Now, yes. Yeah.
Yes, now it's visible to us.
Yeah.
Okay.
Just 1 second. Are you able to see the full screen?
Yes.
Okay, perfect. So I can start. Good afternoon to everybody. And it is a great pleasure. I am Marco Morabito, and I am a researcher of the National Research Council, the Institute of Bioeconomy in Italy. And it is a great pleasure for me to show you a state of progress of the World Climate Project that I have the pleasure to coordinate, and that is founded by the National Insurance Against Accidents at Work, the INAIL. The topic is occupational exposure to extreme outdoor temperatures, and the National Call for Collaborative Research, the BRIC 2019. And no. Okay. The project started 2 years ago, started 1 year ago in June 15 of 2020, and has a duration of 2 years, so it will end next year in 2022 in June. I am the principal investigator, and I coordinate this project together with the colleagues from INAIL, the Department of Occupational Environmental Medicine, Epidemiology, and Hygiene. And it involves, again, 4 partners, one from the epidemiology unit, the Department of Prevention of Central Tuscany Local Health Authority in Florence. The other is the Regional Public Health Laboratory in Siena, and the Department of Epidemiology of Lazio Regional Health Service, and the Tuscany region, the LAMMA Consortium about weather forecaster researcher at the Laboratory of Monitoring and Environmental Modeling for Sustainable Development in Sesto Fiorentino, Florence, Italy. Here you can see the work group involved in this project. And the main aim of this project is to deepen the knowledge on the effect of environmental thermal stress conditions on workers, in particular heat stress, with specific attention to the estimation of the social cost of injuries at work, and this throughout the INAIL injury database. And this main aim will be achieved throughout the organization of ad hoc case studies in selected companies in the area of Central Italy, and throughout the organization surveys on workers' perception, and linked to exposure to extreme temperatures. The proposal for organization solution and operational procedures against heat stress, and the development, that is the core of the project, of an integrated weather, climatic, and epidemiological heat alert system specific for occupational sectors. All this information that will be developed in the field of this project will be published on the platform on the physical agents portal that is involved in the project. The project is organized in 5 work packages. The first one is typically addressed to epidemiological analysis for the social costs estimations of injuries at work related to extreme temperatures. And we are still working on these topics with the head of this work package, that is the Department of Epidemiology of Lazio. And the work page 2 is coordinated by the National Research Council and is addressed to local weather and behavioral monitoring, so the organization case studies in selected companies and survey on the risk perception in occupational sector. In particular, the activity are addressed to weather monitoring during the summer period in representative companies located in central Italy, and analysis addressed to evaluate the productivity loss caused by heat stress, and the identification and implementation of risk perception questionnaire and evaluation of thermal environment, so thermal comfort and discomfort in workplaces during specific test days, and also the development of a national web service about thermal risk perception in the workplace. In addition, we are also involved in tests concerning the performance of ventilated garments, in particular our jackets, that we are testing we would like to test in selected companies, but because the pandemic, we are now working in characterizing this kind of garments in climatic chamber, because it is possible also in this period. So we started last summer, in summer of 2020, with case studies in several industries in the Tuscany region. On this slide, you can see several figures, several pictures of macrometeorological monitoring, where we are monitoring the main meteorological parameters for the assessment and evaluation of thermal comfort outdoor. So the global temperature, air temperature and humidity, and wind speed. And in addition, we also started with physiological monitoring on workers involved in different working activities. And in particular, we collected measurements about heart rate by using polar watch, energy expenditure, average body, and skin temperature. And we also collected thermal images through our thermocamera, and collection of subjective information, the perception and evaluation of thermal environment throughout the submission of a specific questionnaire addressed to evaluate the subjective response to heat stress of workers. And in addition, we also developed 2 heat-related work risk perception questionnaires. The first one that you can see on the left is a national survey on heat-related work risk that is also now available on the project website. And this is the goal of this national survey is to investigate the perception and knowledge of the effects of heat in the workplace in order to identify intervention strategies to reduce the risk of heat for the occupational sector. And the other question that you can see on the right of this slide is related to the evaluation of thermal stress associated with personal protective equipment among healthcare workers. And in particular, this latter, the results that we collected last year about the second questionnaire were already published on an international journal this year, the International Journal of Environmental Research of Public Health, where we found interesting results. And in part of personal protective equipment, the thermal stress perception was very high on the body areas directly covered by these devices in 78% of workers involved in the study. And workers who use masks for more than 4 hours per day perceived personal protective equipment as more uncomfortable compared to the others and reported a great productivity loss. The questionnaire that we used was an adapted version of a tool developed by other authors and that were used in a previous study to assess the knowledge, the attitudes, and the practices of healthcare workers in other countries in Asia, such as India and Singapore, concerning the personal protective equipment usage and its stress during treatment and care activities, in particular during the COVID pandemic. This is another activity where we are involved, that is the evaluation of thermal properties for ventilated jackets, and in particular, the thermal insulation and evaporative resistance. As I already said, we are actually not able to test this jacket directly in the field just because the restriction caused by COVID. But we are testing this jacket and we are characterized these ventilated jackets in a climatic chamber where we are making dry and wet tests to characterize the thermal insulation, the dry test, and the evaporative resistance, the wet test. And we are carrying out several analyses on the nude mannequin, on the mannequin just dressed with jacket, and by using different velocity of the ventilated jacket, and on mannequin with a different ensemble and ensemble plus jacket. And several of this information we have already submitted the first part of this analysis on an international journal, while we are completing the other analysis concerning the wet test. The work package 3 concerns the identification, development of organization solutions and operational procedures. This is coordinated by the Regional Public Health Laboratory of Siena, this work package. And this is addressed in particular to the definition of strategies and solution, technological solution addressed to counteract the heat stress. We are actually involved in the development of infographics concerning the heat stress. The core of the project concerned the work package 4 that is addressed to the development of an integrated weather, climatic, and epidemiological heat health warning system for different occupational sectors, and feasibility study of a cold health warning system, because we are also studying the effect of cold, the extreme temperature in general, with a specific attention to heat, but also with a look to the cold effect. And this work package is divided is organized in different activities. The first one is a review on the existing heat health warning systems addressed to the occupational sectors. And the second activity is the evaluation of the performance of the meteorological models that will be used for operational purposes, and the development of a web forecasting platform integrated with a mobile application. This is the first activity that we already completed, because we are now almost at the half of the project duration. And this is the report and the review of heat warning systems and the selection of indicators to be used to assess the impact on workers that is available on the work climate page. And it is very important, the identification and the selection of the indicator that can be implemented in a heat health warning system to provide a first screening of the possible risks associated with heat stress, and that can be used by stakeholders and workers, taking into account various occupational exposure scenarios. The main characteristics are that it should be easily to use, simple to understand, and it should allow you to simulate multiple exposure scenarios. So which kind of indicators should be used? Should it be a rational index or empirical or direct index? How many variables should be considered? The selected indicators should provide information that can be differentiated as much as possible for the various environments and conditions to which the workers are exposed. And it should consider all the meteorological variables which, on the basis of the scientific literature and the international occupational standard, are responsible for the best evaluation of the thermal stress in the workplace, also accounting for the metabolic rate and the type of clothing worn that interfere with the perception of the thermal environment. So after our investigation, we found that WBGT, that is the wet bulb temperature, and the PHS, that is the physiological heat strain, that are two international reference, are currently the only systems developed at the international levels for its stress evaluation, specifically addressed to the occupational sectors. And these represent the most suitable methods to quantitatively describe the thermal environment, and therefore for an assessment of the microclimate risk due to heat stress. And with the aim of identifying the right compromise between the characteristics of the meteorological model that will be used, the forecast model, and the quality of the heat risk forecast information, the empirical WBGT indicator represents the best choice to perform an initial screening of objective assessment of thermal stress for workers, taking into account the various exposure scenarios to which workers are exposed. The WBGT is an empirical index that was developed in 1950s as a basis for monitoring its stress in US military training camps, and subsequent implementations have allowed an expansion in its field of use, taking into account fundamental experts in the occupational fields such as clothing, personal protective equipment, as well as the level of acclimatization of the subject and the type of activity performed, so the metabolic rate. And the WBGT is now the most commonly used thermal stress index in the workplace, used to ensure that the average body temperature of a worker does not exceed 38 degrees Celsius. And this index is used for the heat stress prevention on healthy subjects in the absence of individual thermal susceptibility conditions. And as you can see on this slide, WBGT allowed the calculation of the thermal stress, accounting both for shade condition and in sun conditions, considering the combination of the natural wet bulb temperature that depend on humidity, air temperature, and wind speed, the black block temperature that depend on radiation wind speed, and the air temperature for estimating heat stress, as I said before, in sun conditions, so accounting for the direct shockwave radiation, and in the shade, so no direct shockwave radiation. And WBGT allow a personalization of the metabolic rate that is used for the calculation of the customized recommended alert and exposure limits, the RAL and REL, for unacclimatized and acclimatized workers, respectively, as well as for correcting the WBGT focus for insulation effects from clothing and personal protective equipment worn by workers, that is the WBGT effective. And at the end, the final output is the customized heat-related occupational risk level forecasted for a specific day that is obtained from the percentage ratio between the WBGT effective, that is the focus of WBGT corrected by the clothing worn by workers, and the customized REL and REL obtained following the previous equations. As you can see, the estimation of some fundamental variables of the calculation of WBGT, in particular the globe thermometric temperature, have already been implemented in the operational weather chain under development throughout what is available in the literature and by using R packages that are already available. But we already made an evaluation of the best performance of the meteorological methods that will be used for operational purposes in work climate project. Here you can see 3 different meteorological models that we tested with different spatial resolutions from 7 kilometers to 2.5 kilometers of resolution, and with different temporal resolution, because the BOLAM has a resolution until 5 days focus, while the MOLOC has a resolution, a temporal resolution until 3 days. And we collect data measured all over the Italy, and the comparison generally showed between focus and observed WBGT values showed a fair agreement between the observed data and those predicted by models. Our attention, however, was addressed especially to the use of the BOLAM focus model, just because it allows a focus until 5 days, and also because the lowest spatial resolution, 7 kilometers of spatial resolution, it has a best performance about time of calculation. And we also evaluated the performance of the model because in some cases the focus is not so very well performance, just because there is a difference between the altitude of the model and those of the real situation. And on this slide you can see the area where with the particular morphology where the focus are not so very good. This is the prototype of heat stress forecasting system that we developed in the field of work climate. This is an experimental activity for use by workers. It is already available on the website, employers, occupational safety and management professionals, and information relates to a healthy workers not acclimatized to heat and exposed to direct sun or shade and engaged in intense or moderate outdoor physical activity. A user can choose whether you work in sun or shade, and if you do intense or moderate physical activity, and then you can see the maps. And this forecast will soon be complemented by a mobile application that will allow personalized forecast based on workers' personal characteristics, such as the height, weight, the physical activity, the type of clothing worn, and the working environment if you are exposed to the sun or shade. As you can see, these are the forecasts for 3 days with the risk legend, with different risk level from known to low, moderate to high heat stress risk. Here there is just a simulation of the forecast of the heat risk for workers in the sun for 2 days ago. On the left is in the sun, and on the right is in the shade. As you can see, two completely different situations you can focus, and this information could be very useful for workers, stakeholders that can adapt their work based on the heat stress risk. And at the end, there is the work package 5, that is the scientific dissemination presentation, the results to stakeholders. We already presented our results to several national and international conferences. The last is the occupational health and public safety of today, thanks to this opportunity. And these are the first project publication that we already carried out. One is related to how heat warning should be adapted to the time of the COVID-19 pandemic that we published last year, and the other is that I mentioned during this presentation. And there are other 2 manuscripts that we already that are in submission phase. One is concerning the cooling garments against environmental heat condition in occupational fields, so measurements of the effect of a ventilation jacket on the total thermal insulation, and the other is concerning a high-resolution heat health warning system for outdoor workers in Italy, a climate change adaptation strategy to protect workers' health and productivity. Thank you very much for your attention, and I am available for questions.
Thank you, Dr. Marco, for your presentation. Is anyone having any questions? Okay, thank you once again for your presence and presentation.
Thank you very much.
Okay, moving on to our next presenter, Dr. Angelica Guswell from Hesso University, Switzerland. Hello, Dr. Angelica. Are you ready with your presentation?
Yes, I try to share this.
Yeah, just a minute. Yes, you are the presenter now. Now you can share your screen with us.
Yeah. Okay, can you see it now?
Yes, yes.
Okay. Is it okay like this?
Yes, yes.
Okay, so I'll start. Good afternoon, everybody. It's a bit special to talk to all these people. I don't know who is there, but be welcome in any case. I'm pleased to have this presentation about music drops at work, which is an intervention research that we conducted at Haute École de Musique de Lausanne, which is a music university of Lausanne, located in the French-speaking part of Switzerland. Music Drops at Work was financed by the Swiss National Fund for Scientific Research, which I would like to thank at this point. And the main objective of this project, as its subtitle indicates, was to implement brief musical interventions in the work context and then to study their impact on both individuals and teams. So to do this, we needed an interdisciplinary team. You can see the team here. It's in Lausanne. You have a sightseeing of Lausanne. So I'm a psychologist myself. And then we have Sarah Gebalman, who is our assistant. She is sociologist. And we have Katrin Imseng, who is a musician, a pianist and organist, and a teacher. And I think the complementarity of this discipline, of our knowledge, of our skills, as well as the crossing of our perspectives, was very important for this project. You will see why later. The starting point of this intervention research is linked to the musician's profession. The economy and the job market of music have changed a lot in the last years between budget cuts, reduction of subsidies, aging of the public, and more recently, the total upheaval of the world of culture following the health crisis of the COVID-19. As a result, musicians are in a precarious position, and professional integration is a real issue to them. Our graduates are looking for innovative ways of transmitting, sharing, and mediating on music. They are also looking for new areas of activity. And so the world of work and business might be a new area of activity. And so we started thinking about a way to connect the world of music to the world of work. For that, we went through literature, and 3 different fields caught our attention. First, the idea of social innovation in companies. We are seeing the emergence of new human resource management practices aimed at better taking into account the needs of employees. For example, by modifying the specifications, by encouraging autonomy and individual development, or by setting up activities that strengthen intra-team links. Second, music at work. During the 20th century, numerous studies have examined the impact of music and music listening on workers. These studies have evidenced a reduction in boredom and fatigue and an increase in productivity. In the 1930s, the Muzak company started developing so-called functional music, a music composed specifically to improve well-being and to increase productivity. This instrumentalization of music was strongly criticized, notably by Adorno. And then we have listening together as a situated collective practice. Here we are in sociology. The concert situation is very different from individual listening, since it is co-elaborated and brings into play and into activity all those who participate, musicians and listeners. It is therefore a moment of doing and being together, and not an activity of each one for himself. So after these few theoretical elements, let's move on to the concrete development of the project. So as I said in the beginning, the question was, what is the experience and impact of brief live music interventions in the work context? And as I also said, it is an intervention research. So the idea is to implement a new collective practice in 3 Lausanne companies. I will introduce these companies right away, but first I would like to explain how the experiment went. In August 2020, a piano was installed in each company, and this piano remained there for 3 months. The employees were informed about the project and filled in a preliminary questionnaire about some socio-demographic data, about the place of music in their lives, about their commitment at work, and about their general emotional state. And then for 12 consecutive weeks, from September to November, 10-minute mini concerts were offered during working hours in each company. After these concerts, every time, the listeners filled in a short questionnaire about their appreciation of the music and their subjective experience. And at the end of these 12 weeks, focus groups were conducted with volunteer employees, and individual interviews were held with the manager responsible for the project internally. Final step was in May 2021. A few weeks ago, a review of the main results of the project was given in the companies, followed by a final concert, this time lasting 30 minutes. So now next I would like just to present shortly the three companies. We have three very different working contexts. We have a car garage, a car repair service where we had concerts. Then we had an engineering office. And finally, a kitchen sales team, so they are selling kitchens. These three teams are quite different. The socio-demographic data we collected highlight some of these differences. The teams of the engineering office and of the car garage are younger than the kitchen sales team. In terms of educational background, and this is not surprising, the engineering office has the highest but also the most diverse level of education. No significant differences in terms of hours of weekly music listening. Finally, when it comes to musical practice, past practice and current practice, the kitchen sales team comes out on top, followed by engineers and finally by garage employees. We were also interested to see what these people were listening, what music they like to listen at home or in their leisure time. And we see greater stylistic variety, a greater eclecticism among the salespeople than in the two other teams. And I would like also to highlight that the classical music is only mentioned in this specific team, so in the kitchen sales team. And this is important because the music which was played and these little concerts was always classical music, because our students play classical music. So let's come to some results. First of all, quantitative results. As mentioned earlier, before and after each musical intervention, listeners answered a few questions about their subjective experience. And we see here how, on average, they rated their emotional state before and after the mini concerts. The car repair team seemed to arrive and to leave after the concerts more or less in the same emotional state, situated somewhere between inactivity and calm, closer to inactivity. For the employees of the two other companies, the moment of listening to music seemed to induce a change that went in the direction of an increased well-being. Employees indicated arriving in a calm state and leaving in a more pleasant state. We were also interested in the relationship between socio-demographic variables and subjective experience. The present table shows significant correlations between the level of education and bodily sensations, the fact of forgetting reality, and the desire to share with others. So, educational level is an important variable. Furthermore, personal music practice is correlated with bodily sensations during listening, as well as with music appreciation. So this is the second important variable. Age, sex, and the hours of weekly music listening in turn seem not to be correlated with the appreciation of music or the subjective experience of the music listening moment. Let's now turn to some qualitative results from the focus group analysis. The objective of this analysis was to see if the listening moments had an impact at the individual or at the collective level. On the individual level, what we can see is that the mini concerts seem to have been experienced as moments of pause and relaxation. Images like open window or get some air were used, or some fresh air, sorry, were used regularly. Antonio also says, well, it's true that listening to music relaxes. The mini concerts induced emotions and allowed the listeners to connect to their own emotional experience. Gabriel says it creates an emotion, and Nien explains, yeah, it was very strong. I was moved the first time and I almost had tears in my eyes. It was quite a strong emotional experience. The mini concerts were also experienced as moments to oneself. And this idea came up often in the narratives. The mini concert were moments that people did not necessarily want to share with others, but they wanted to keep and live for themselves. And we have Anne who says, often I close my eyes because I don't want the reaction of someone next to me to have an impact on what I'm thinking. I close my eyes and I live for myself. I don't want the outside world to interfere with what I'm thinking. So that was about the individual impact, and we come now to the collective impact or the collective way of experiencing the mini concerts. We see that they allowed, first of all, to meet. It allowed us all to see each other for a little while during the day, whereas normally we don't meet. Of course, there are breaks and so on, but we don't necessarily all take our breaks at the same time. And nowadays, with the restrictions, this is COVID, we can't be more than a few people at the cafeteria and so on, explains Anja. The mini concerts also allow to exchange or to create link. Maiwen says, that's important because at the office, we often talk about our job. Sometimes we discuss other things, but it creates an opportunity and then a subject or an event like that. We exchange emotions, ideas. I think it creates link. The concerts also allow, sorry, I'm a bit with my PowerPoint, it's a bit chaotic. It allows to get closer. In any case, says Claude, I think that the collaborators got a little bit closer because we felt the same thing. There's a little bit of a connection because you like the same things. And finally, the concerts and also what happened after the concerts allowed to get to know colleagues better. Adrien says, yeah, and maybe it also allows us to discover something in the other person that we don't imagine or at least don't know about him or her. It's not easy to get into the personality. I mean, yeah, I wouldn't go so far as to say into the personality of the other person, but to get to know people a little bit more on a personal level. And I think that it was also quite positive. Because it's true that suddenly a colleague started playing the piano. She played a little bit of Amélie Poulain, and it was really cool. And we didn't necessarily expect that from this specific person. So that was interesting because the piano stayed in the office for 3 months. So there was opportunity to use it apart from the concerts. Let's come to some discussion points and to some concluding remarks. First of all, with respect to our research question, we can say that the musical interventions were globally very appreciated and that they had a positive impact on the individuals as well as on the teams, allowing a moment of self-recovery, a connection with one's emotions, as well as exchanges and reinforced links with colleagues. However, it turns out that the nature of work and the structure of the companies mediated this positive impact. The additional break time was experienced as something pleasant by the sales teams and the engineers who are relatively free in the organization of their time. On the contrary, for the car repair team, these extra breaks were perceived as moments of inactivity, more stressful maybe than pleasant in view of the amount of work to be done. And what's more, as a constraint imposed by the hierarchy. We asked ourselves whether the music drops at work interventions could be considered as a social innovation. It is an innovative practice, for sure. However, it is limited in duration and time and can therefore not be expected to have a lasting impact, which is a crucial dimension of social innovation. Furthermore, participation in the project was negotiated with human resources managers and therefore decided top-down. It did not involving all the actors concerned, another crucial dimension of social innovation. We can therefore say that the Music Drops at Work project lays the foundations of a social innovation, but there's still a way to go. Final idea. Within the context of a funded research project, it was possible to offer the series of 12 mini concerts for free. So the 3 partner companies did not have to pay for the musicians to come. All were enthusiastic about the experience and asked if it could be continued. When informed of the costs this would entail, all chose to stop, citing the uncertainty of their health situation as the reason for this decision. Companies that launch and finance social innovations expect a return on investment. It's normal. Thus, the challenge for the continuation of the Music Drops at Work project and more generally for the introduction of music in the context of work lies in highlighting the tangible spin-offs and concrete benefits that it can have for the companies. These are some references, and I don't know if maybe there are questions. Thanks a lot for listening.
Thank you, Dr. Angelica, for your presentation. Is anyone else having any questions? Okay, no questions from anyone. Thank you once again for your presence and your presentation.
Thank you.
Okay, so our next presenter is Dr. Anthony V. Hinson from University of Abomey-Calavi, Benin. Hello, Dr. Anthony. Are you ready with your presentation? Hello, Dr. Anthony. Your voice is not audible to us. We can able to see your screen, but your voice is not audible to us. I'm sorry, Dr. Anthony. We cannot able to hear you. No, sorry, I'm sorry. We are not able to hear you. We can able to see your presentation, but the voice is not audible to us. Can you please check with the the speaker phone which you are using?
Are you hearing me now?
Yes, yes, yes. Now it's audible. Please continue with your presentation.
Are you hearing me?
Yes.
Okay. Are you seeing my screen?
Yes.
Okay. Let's see. I'm Dr. Inson Antoine Viquet. I'm a researcher at the University of Abomey-Calavi in Benin. I will share with you the research we have done in a neighbor country, which is calling Burkina Faso. It's the title is prevalence of and the associate factor of burnout with healthcare worker of Ahiguya Hospital situated at Burkina Faso. The content is after introduction, we will discuss about the framework study and the method after giving you the results and with the discussion we have about the results. Then we will conclude. What can we say in introduction? We say that for modern society, work is a valued activity, even essential to well-being. However, it sometimes takes on a detestable aspect and can be a source of wear and tear on health. In this respect, the physical risks are widely recognized, while for psychosocial risk, a multifaceted problem still arises. Burnout syndrome is one of the most current psychosocial risks. According to Maslach, burnout is a three-dimensional syndrome involving emotional exhaustion, depersonalization, and reduced personal achievements at work or professional effectiveness in individuals who are professionally involved with others, especially in a caregiving relationship. As we can see, burnout can look like little to no motivation, insomnia, emotional overwhelm, amplified anxiety, exhaustion, easily triggered. On the epidemiological level, Shadowfeld found that the prevalence of burnout was increasing from 45% in 2011 to 45%. The burnout rate rose to 45% in 2004 among American doctors. As for its consequences, burnout alters the health and well-being of workers and cause economic loss. The hospital is a professional environment at risk, and the nursing staff is a population particularly worthy of interest because the quality of health care depends directly on the health and well-being. However, in the context of Burkina Faso, we found only one study on the burnout of healthcare workers. And in this pioneering study, the associate factors were little explored. Hence, the conduct of our study as a contribution to the need to fill these gaps. The general objective of our study was to evaluate the prevalence and factor associated with burnout among nursing staff at the Regional University Hospital of Ouahigouya. More specifically, the aim was to determine the prevalence of burnout, describe the characteristic of burnout, and identify factors associated with burnout in that hospital. What is the study framework and the methods? The setting was at Burkina Faso, situated at west of Africa. The study setting is the hospital, one big hospital, university hospital in Burkina Faso. It was a cross-sectional study, describing analytical and observational study, which we conducted from 1st of July to 30 of September 2020. The study population consists of the nursing staff of the center. The study includes staff working in a clinical department with at least 6 months seniority and who freely consent to the study. Our sample consists of 149 caregiver recruits by voluntary no probability sampling, a generic questionnaire in addition to validated questionnaire serve as collection tools. Burnout is assessed by the Baslash Burnout Inventory Score, composed of 22 questions. Each dimension has a number of questions whose total gives it a score that gives it a low, medium, or high level. A high score for emotional exhaustion or depersonalization, or a low score for professional achievement is sufficient to speak of burnout. Degree. 1 dimension reach low burnout. 2 dimension affect mean moderate burnout, and 3 dimension affect mean severe burnout. Burnout as a psychological syndrome involving emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment that occur among various professionals who work with other people in challenging situations. The independent variable includes socio-demographic, psychosocial factors from the Karasek and Segris questionnaire. Using Stata software version 13, we produce, describe statistics, and perform logistic regression to identify associated factors with a significance level of P0.05 for all tests. What are our results? And then what results have we achieved? And what comments can we make? Regarding socio-demographic characteristics, the 149 caregivers had an average age of 38 years, with a male with a sex ratio of 1.56. The vast majority were in union and had at least 1 dependent child. The characteristics are reminiscent of the profile of worker at the Sorosano University Hospital in Burkina Faso in 2018 study. When psychosocial factors were assessed using the Segris scale, we obtained an average effort per reward ratio of 0.75. This is close to that found by nigger in Cameroon at the Yaoundé Central Hospital. This is close to the ratio found by nigger in Cameroon at the Yaoundé Central Hospital. On the other hand, this average ratio, as well as the percentage of unbalanced ratio in our study, are clearly lower than those found by Jabor in France. This difference can be explained by the difference in the study population, which in our survey was made up of all the hospitals caregivers in general. The exploration of psychosocial factor according to the Karasek scale in our study found average score of 30 for decision latitude, 25 for psychological demand, and 21 for social support. Their score reflects respectively high decision latitude, high psychological demand, and low social support at work. Our results are similar to those of Jabor, but the state of stress found in 27% of the staff in our survey was more widely described by the same author, which is understandable when comparing the activity of a hospital in general with those of an emergency department in particular. Overall, the prevalence of burnout in our study was 48.32%. This result, which is almost identical to that of Bonkugung found in his study, can be explained by the organization similarity between the two university hospitals in the same country. On the other hand, it's much higher than that of Odontor and Bagabatula, the delay in Burkina Faso in terms of policy and measures to prevent psychosocial risk in hospital could explain this difference. In our study, the main score of dimension were 26 for emotional exhaustion, 9 for depersonalization, and 34 for personal accomplishment, corresponding to moderate impairment of each dimension. Our results are corroborated by those of Neguin in Cameroon. The proportion per affect dimension were as follows. The emotional exhaustion score was high in 36%. The depersonalization score high in 23%, and the personal fulfillment score low in 32%. Their proportions are close to those found by Bogonku and differ greatly from those of Turkey. These differences can be justified by the fact that our study includes hospital caregivers in general and not only those in emergency departments. In our study, more than half of burn caregivers suffer from a moderate degree of impairment. In contrast, in Bonkuku studied, the predominant degree of impairment was low burnout. Our results call for preventive action to avoid the evolution toward severe burnout. Factors associated with the presence of burnout syndrome. In our study, women were twice as likely to suffer from burnout as their male counterparts, which is corroborated by the Al-Ghatani study. The results confirm that the theory that women are more susceptible to burnout Albert, in the Vatula study, men were at greater risk. The use of sleeping aids was associated with burnout in our study as well as in the literature. However, it is less clear whether this addiction is causal or consequential to burnout. The profession of physician was a risk factor for burnout in our study. These results, which is contrary to those of Moss in Canada and Bankugu in Burkina Faso, can be explained on the one hand by the higher professional expectation of physicians, and on the other hand by the heavy responsibility they have as manager of healthcare team. Effort and reward score were associated with the occurrence of burnout in our study as well as in those of Scots and Jabo. Low social support at work and lack of time for my family favorite burnout, which reflects the importance of both professional and private social relationship in the development of burnout. However, this association was not found in Jabo's study. Emotional exhaustion was favored in our study by unavailability and low social support at work, further confirming the role of good social relation as a resource for burnout. These results are in agreement with those of Clay and Hostler. The imbalances effort per reward ratio favored the occurrence of emotional exhaustion in our study, as it did in those of Lu in China and Schultz in Germany. These results confirm Sigrid's theory, according to which the mismatch between effort and reward is a source of exhaustion at work. However, this link was not established in Jabo's study. With regard to depersonalization, the association with psychological demands, effort per rewards imbalance, and the use of sleeping aids found in our study is corroborated in the study by Prekel and Catebrat. This could be justified by the psychoactive action of tranquilizer on the brain on the one hand, and on the other hand by the stress generated by the high psychological demands at work and the imbalance between effort made and reward received. The loss of personal accomplishment was favored in our study by the low reward score. The status of university teacher was protective of a loss of personal accomplishment. This association can be explained in our study, our context, by the added value attached to this status in terms of honor, gain, and professional achievement. Jabo, on the other hand, did not find a significant association in his study. In conclusion, we can say that prevalence of burnout had a prevalence of 48.32% among healthcare workers at the Regional University Hospital of Pakihuya in Burkina Faso in 2020. Emotional exhaustion was the main dimension affected. The preponderant degree of burnout was moderate. Factors favoring burnout were female gender, use of sleeping aids, lack of time for family, low social support at work, being a doctor, high effort and low reward. It is therefore necessary to extend the study to all workers for more completeness in a prevention perspective. Thank you for your kind attention.
Thank you, Dr. Antony, for your presentation. Is anyone having any questions? Okay, there are no questions from anyone. Thank you once again for your presence and presentation. So our next presenter is Dr. Paula Tukey and Jessica Artiega, South Riverdale Community Health Center, Canada. Hello, Dr. Paula.
Hello, and not a doctor, just Paula is fine.
I'm sorry, Miss Paula. So I'm ready with your presentation.
Yes, we are ready. I guess, oh, sorry, gotta screen share.
Yes. Yes, it's visible. You can start your presentation.
All right. Thank you so much for joining us. My name is Paula Tukey, and I work at the Keep 6 Consumption Supervised site at South Riverdale Community Health Center.
And my name is Jessica Artiega. I'm a registered nurse here at South Riverdale, working specifically in the consumption and treatment services or supervised consumption services here at South Riverdale.
Oh, how do we, sorry. Very good. All right, so just I don't want to be assuming that everybody knows where Toronto is. So Toronto is the largest city in Canada. We have almost 5.5 million people. Ontario is sharing a southern border with the US, and the border is about a couple of hours drive from Toronto. Even though Toronto in Canada is a wealthy place, we have about 8,700 people who are completely homeless living in Toronto. And the climate goes from very hot and humid in the summer to very, very cold in the winter. This is just for your orientation, a map of Toronto. Our site is the most on the right, South Riverdale Community Health Center. The image of the center, that's us. Our main population that we focus on are people who are homeless, people who use drugs or are otherwise marginalized. South Riverdale has one of the largest harm reduction programs in Canada, if not the largest. So I think that that's a common experience in the world. And just like everywhere else, we've been experiencing increasingly more deaths from opioid overdose. In Toronto, historically, the drug of choice has been stimulants, but about 6 years ago, opioids and injection drug use increased extremely, with street fentanyl became available and very quickly became the most commonly used opioids. The street supply itself is increasingly more contaminated by other substances after other fentanyl analogs, carfentanil, and especially benzodiazepines, making the overdose crisis worse. There was an expected about 2,300 opioid-related deaths in the province in 2020, but the numbers are very much underestimated. This is just for your information. You can see in the graphs the deaths and the impact of the overdose crisis increasing. The link in the bottom of the slide is a link to the most recent coroner's report, kind of talking about the overdose situation in Toronto, or in Ontario, sorry.
So overdose response work is rooted in the principles of harm reduction and trauma-informed approach. This is an approach where healthcare providers meet people where they're at. We do not judge them for their drug use or require them to change in order for us to provide care. It is about our clients' personally defined goals and not ours as providers. It also requires us to understand that systemic barriers such as criminalization, racism, poverty, colonialism cause a lot more harm in people's lives than the actual use of drugs. I'm going to give you an example. Fear of criminalization causes people to hide their use, and people use in dangerous places like alleys, often alone. It also causes people to use quickly to avoid being arrested. This increases their risk of overdose. As you can see from this example, none of those harms are actually caused by the use of drugs themselves. It is all due to poor policy. Our jobs would not exist if we had proper policy that treated people who use drugs with respect. We must recognize that people use drugs for a variety of reasons, and often it is a way to manage pain, from physical, emotional, and spiritual. Another important concept in harm reduction is nothing about us without us. This means prioritizing the autonomy of people who use drugs. I am privileged to work alongside many coworkers with lived and living experience, and they have taught me to be a better nurse and provide better care. This job required me to unlearn many of the harmful concepts taught to me in my nursing education, and to self-reflect on many of my own biases and how these are projected in my work. We must recognize that harm reduction was developed by people who use drugs, and that none of our advancements would exist without them. Bad policies in other spheres of society directly impact the wellness and occupational health of our staff, who are people with lived and living experience. This work only exists because of societal and political failings. Our goal is to work ourselves out of a job.
So where it all started. So what you see on the screen is in 2017, when the overdose crisis really started to impact people, and we were losing, people daily, weekly in numbers that were quite atrocious. Even though the government has been already working on setting up a safe consumption site that were exempt and run and funded by the government, the work was so slow that activists started set up tents in a park, in a mass park. In the map, you see kind of the really, really dark area. That's kind of where the images from the park are. And so we started working in the park. One tent was for safe injection, where, oxygen, a nurse, and another staff person would be observing the consumption and making sure that response was available if needed. Another tent was for chill and recovery. So this was our very first workplace. There was about 150 volunteers from all over Toronto. People were really fed up with the government, so this was one way how the work started. And actually, this action sped up the process of opening the formal sites. Mass Park, which that's what the park is called, is now indoors, called Mass Park, and it's one of our sister sites agencies.
So what is a supervised consumption site? It all starts as a special place where drugs are legal. Once you enter these doors, possession and the use of illicit substances is permitted and legal. These are our supervised consumption sites. One of them is Moss Park, the other one is Keep 6. We're both under the umbrella of South Riverdale. And most sites look very similar to this. In Canada, there are currently 37 safe consumption sites offering services. Basically, it's a place where service users can bring pre-obtained drugs. We provide them with gear, a safe place to use, food, coffee, and intervention if they overdose. Gear can be for snorting, injecting, or orally consuming drugs. Unfortunately, we currently do not have a service for inhalation indoors. In 2019, we were rebranded by the Ontario provincial government as Consumption and Treatment Services. The government wanted us to have a heavy focus into sending clients for treatment, for example, detox or rehab. Despite this, they never increased the number of treatment beds available, and it's actually been very difficult to get anyone into a detox bed as there are no beds available. We like to think of treatment differently. Treatment is an individualized concept and means something different for everyone. We use art, traditional indigenous medicines, music, or whatever somebody defines as their treatment goals. But we are more than just a safe injection site. We are a community. We take care of each other. Again, I have the privilege of working with some of the most amazing people. Our community members are wonderful, caring, smart, and funny. Our staff makeup is very interdisciplinary and unique. In the space, we have a community health worker. They assist with case management and psychosocial aspects of the work. We also have a registered nurse who provides low barrier healthcare. And most importantly, we have overdose response workers. And this is a group of people with lived and living experience. They guide our work, build strong relationships in the community, and in reality are the reasons we are so successful at our work. Although each role is specialized and vital, we often work within each other's realms. We all contribute to the same tasks and work together to create an amazing space. Some of the things we do include wound care, emergency interventions in an overdose, health assessment, medication administration for things like antibiotics or hepatitis C medication, case management for housing, medical appointments, government assistance programs. We do supportive counseling, crisis intervention, point of care testing for pregnancy or urinalysis, vaccine administration, client workshops, phone calls and check-ins. We visit clients in the hospital and advocate for them, and we do outreach to local shelters to provide training and harm reduction supplies. So here again is our site. In the corner here, you'll see this very colorful space. This is our chill out room where clients can come post-consumption and relax before leaving. This mural that you see there is an incorporation of Indigenous and LGBTQ imagery done by my coworker, Les Harper. We have murals and art pieces throughout the site. It creates a more welcoming space and reduces the clinical feel. Art is also healing for people and allows them to connect to their community. In this space, we also have a phone so our clients can stay in contact with their community and family. We would often have art activities, puzzles, and snacks in the space, but unfortunately with COVID, the capacity has become significantly reduced. This is a graph that shows our overdoses from about the time in 2019, in April 2019 to now, April 2021. And you can see the massive upswing in the number of overdoses that we've had. So in the past year, they've almost tripled. In the first year of operation in 2017 to 2018, workers had responded to a total of 9 overdoses. And now in March 2021, our team has responded to 68 overdoses in 1 month. It is expected that this situation will continue to get worse and escalate. So the concept of a safe injection site is relatively new. In Ontario, it's been running for approximately 4 years. Working within a safe injection site requires us to build strong, trusting relationships with our community. This often means we get very close to our clients. We learn about their lives, their joy, their pain. Together, we celebrate birthdays, holidays, and achievements. We also mourn together. It is these relationships that make this work so special, but it is also these relationships that make this job difficult and in some ways an occupational hazard. In no other healthcare service are staff required to build relationships with their client while also watching them ingest a toxic drug supply and overdose. Watching people you love and care about become unresponsive, stop breathing, and turn blue day after day after day. When responding to an overdose, a service user will often slump in their chair, become unresponsive, and stop spontaneous respirations. We often transfer people to the floor and begin emergency interventions, which include oxygen administration and rescue breathing, using a device known as a bag valve mask. When these interventions are not enough, we have to administer naloxone. Naloxone is a medication that is available to reverse opioid overdoses. However, it does cause extreme withdrawal when a service user wakes up, and if service user is not closely monitored, it can cause a secondary overdose. Naloxone is amazing and has saved millions of lives, but it only works on opioids. People can still overdose on drugs like stimulants or benzodiazepines, which there is no antidote. In many areas of healthcare, it is not unusual for clients to pass away. However, in this field, we can never predict who is going to die. Oftentimes, we arrive to work to find out someone has passed away, sometimes alone, and we have no time to mourn. We immediately have to go back to work because if we're not there for our clients, then who will be? We notice that clients haven't been seen for days, so we perform wellness checks, which often result in us finding clients dead in their apartments or outside in tents and porta potties. Sometimes we never find them and we wonder if they're alive or lying in a morgue with hundreds of unclaimed bodies. We also witness a lot of violence. This violence comes in various forms. Violence from a system, our clients facing police violence, institutional violence, and violence from within the community. Sometimes staff are on the end of those violent outbursts as well. Often our clients have nowhere to express their frustration, and it manifests into behaviors that we often need to de-escalate. No human should have to endure this type of abuse from society and their government. These are human beings who deserve love, respect, and dignity. As an individual, this has caused serious mental health issues, depression, anxiety, trauma, PTSD, and ongoing grief and losses, anger, hopelessness, and issues with physical health. As a program, we see high turnover of staff. We have issues with team cohesiveness as people leave, and challenges to recruit because of the nature of the work and poor compensation. Agencies are challenged with providing adequate or appropriate support, which they are not set up for. They invest in workers who have a very short lifespan, and challenges in recruiting because very few people are interested in doing this work to begin with. Clients are constantly seeing new staff and having to build new relationships. Workers not having the patience or empathy to do this work because of burnout and the challenge of service users and their needs not being met, and services not being able to be open due to shortages of staff. The biggest occupational hazard we deal with is grief, our own grief and the grief of our community. As I mentioned previously, there are no breaks when someone we love dies. We find out and we keep working, because if not us, then who? Oftentimes we hold memorials on our own time, blurring the so-called work-life balance. Once you become so close to a community of people, it's hard to turn off when you are at work. It is extremely challenging, and there's very little support for staff currently in this field. People who are drawn to this type of work often have a lot of their own experiences with substance use and trauma. This puts staff in vulnerable positions with no support, which can result in crises that are often not addressed. And when issues are not adequately addressed, we lose staff. Sometimes they go to other jobs, sometimes they leave the field altogether, and sometimes they end up dead. From my own experience, I have found it difficult to relate to people outside of this field of work. It is hard for me to explain to my family and friends what I do and what happens at my job. When people ask me how work is, I often reply with a shrug and tell them it's probably better not to talk about it. I feel like all I have to talk about is bad news. The following images that you see below, we have here a drug user memorial that is outside of our building with a list of names of people who have passed. Again, that list is continuously growing. We hold protests very often to the Board of Health, just to stress how important it is for us to have action taken. And finally, another list, this is a Toronto Homeless Memorial, which each year lists the number of people who are experiencing homelessness who have died. Again, there is a memorial that we held on Monday, June 14th at City Hall in Toronto. We went to remember all the people we lost and are reminded to remind our government that they are not doing enough. We organized this on our own time, many people working full-time jobs. It's hard to look at these photos because we see everybody we have lost. But we set up memorials to provide support for each other. Being together to grieve has helped us work through pain. And through a global pandemic, coming together as a group has been increasingly difficult. Often we hold memorials and healing circles outside.
So despite the service being considered an essential service, especially during COVID, where a lot of other services shut down or minimized their operation, we actually became busier. So despite that it is essential service, the formal or mainstream available supports are limited and often ineffective and even inappropriate. they're also not always accessible to all workers. As Jessica mentioned, we have a lot of people who are community members, who are peer workers, and they often are not eligible for the same kind of benefits as other workers would be. Some of the formally available ones is employee assistance programs, which is super mainstream and generally not at all helpful even to workers who are not necessarily workers with lived experience. Our employment benefits that we have through work are not sufficient and definitely not cover a lot of helpful assistance. The affordability of resources, nothing is fully covered. So, people don't often have the resources to cover themselves. And also the lack of understanding of the nature of this particular work and overdose response work makes, getting support through mainstream therapists challenging. So as a result, frontline workers took it upon themselves to create supports with the support of other agencies in the community. And examples of that, these are a couple of posters that illustrate some of the available resources, group supports, one-on-one support. We have ceremonies, healing circles, and memorials. We created, or the workers have created, this is an example of a harm reduction zine. And also we are facilitating alternative healthcare access, massages, acupunctures, and herbs. The zine in particular was created by harm reduction healing group by frontline workers. But what we really need is access to safe supply. This work would not be existing if the drug policies were what they are. The one thing that we feel that would be helpful is increased access to safe supply, meaning prescription opioids that are saved and measured. People would know exactly what they're using at one time. And until that happens, people will continue dying and workers will continue being traumatized and getting burned out at increasing levels. We would like to thank you for your attention and also would like to ask you to please carry naloxone with you and be kind to service use and substance users. We would like to give thank you to all the people that do this kind of work and as well as those that support us in being able to do this very, very challenging work. And here are some useful resources if you're interested in the work being done and the impact that it has. These are some of local Toronto resources that talk about the impact. Here are our contact if you like to get in touch with us and have any questions past this presentation. And we would like again to thank you.
Thank you, Ms. Paula Chuki and Ms. Jessica Tiega for your presentation. Is anyone having any questions? Okay, thank you once again for your presence and presentation.
You're welcome.
Okay, so moving on to our next presenters from Dr. Corey M. Cronrath from Marshfield Clinic Health System, USA. Hello, Dr. Corey.
Hello, how are you doing, Ms. Zina?
Yeah, hello. So I'm going to make you the presenter.
All right.
Yes. Now you can share your screen with us and start your presentation.
All right, 1 second here.
Yes, it's visible.
It's visible. All right. I'll go ahead and start this presentation. First, I want to thank you for having me at the International Conference on Occupational Health and Public Safety. Would have liked to see all your smiling faces back in May of last year, but extremely thankful for Rosina and the work she's done for us to be able to have the conference in this medium. So today, going to speak a little bit about a conceptual model on the adverse reactions of medications and how to risk stratify them within safety sensitive positions that require complex decision making. And this is going to be based off of a publication in the Aerospace Medicine and Human Performance Journal that my team completed. All right. So I'm Dr. Corey Cronrath, board certified in occupational and aerospace medicine with a master's in public health. Started my military career, enlisted in the United States Marine Corps, served a tour with them, and then went to school, became a physician, and joined the United States Army as a physician for residency. Served in one combat tour in Afghanistan and also a second tour non-combat in the Baltics and Eastern Europe for Operation Atlantic Resolve to deter Russian aggression. I enjoyed my time there. My wife asked me to leave the active duty due to the deployment cycles, and so I quit having fun and went and got a real job at Marshfield Clinic Health System in Wisconsin. It's 10 hospitals, 44 clinics, 12,000 plus employees. I'm the service line occupational medical director and employee health director. And I still do Army Reserve part-time with the 75th Innovation Command. So this is a standard non-disclosure. This is based off of a publication. The opinions are mine and not necessarily that of the Department of Army, Department of Defense, United States government, or Marshfield Clinic Health System. I only receive monetary benefits from Marshfield Clinic Health System and the United States Army, no other sources. So what got me thinking about adverse reactions in the team that I was on is, as a flight surgeon, you do risk mitigation, a lot of safety work, but you're also the primary care provider for these aviation crews. And the picture you see on the screen is a very typical light dust landing in Afghanistan. These pilots are flying in unfamiliar terrain. The crews are calling out spaces for them where they can't see. You're landing, picking a spot to land, making a risk assessment while in flight of, is there any enemy threat? And you can see there's a couple packs or individuals waiting, so you want to land close to them so they can run on to your bird and get out of there quickly. So this is happening over and over again, and I'm seeing pilots come in and crew members come in on a plethora of different medications. And when I go through and look at the adverse reactions, whether it's using a lexicomp and Hippocrates or whatever reference you utilize, you see a lot of adverse reactions with them and develop questions of which ones of these are safe and not safe in developing reactions that would negatively impact the mission. The lower one there is a picture of a UH-60, and that's in Germany there, flying in clear blue and 22 good conditions, but unfamiliar terrain, and utilizing actually a lot of different radio systems than they do in the States, and with a variety of different air traffic controllers and rules when operating outside of your country of origin. But the medication and the decision making isn't just in Army aviation or military operations. It's also for bus transportation. These driver operators are making decisions on a regular basis. They have multiple souls in the back of their vehicles that they're responsible for, and each one of us can think back to a bus accident where there was loss of life. For me specifically, it's the Sierra coach crash in Switzerland back in 2012. There's 28 fatalities and 24 non-fatal injuries in that accident, where a driver struck a curb and then ended up hitting a retaining wall. There were concerns of a medical condition, but never made contributory. So are these secondary adverse reactions becoming an issue in the safety in these environments where we know we will have a known accident rate? And can we, as providers, limit that by looking at the medications on board of these driver operators? That's really what started the thinking of this investigative team. And so Matthew Click, an occupational aerospace medicine physician, Chad Murfeld, a PA with many years of operational in the United States Army aviation, and myself decided to try to tackle this issue in a very specific population of Army aviation, really the rotary wing or the helicopter community. So what we did is in residency, I worked with a physician named Michael Prudhomme, who did develop a methodology on how to really risk stratify medications or a framework. So we utilized that methodology, built on it somewhat, and then applied it specifically to the Army Air Aviation community. And that is how we came at the MARS-2 model, the medication adverse reaction risk stratification model. This model does have many strengths, but it does have limitations as well. It's not a fix-all. You can't go through this model and say, yes, this medication is safe or not. It's one data point amongst many. And so let's go into what was the methodology that Prudhomme came up with. And it was really 7 easy steps in determining the concern of adverse reactions of medications in really any kind of workforce. First, determine a reference sample of what is considered historically safe medications within that workforce. So again, we're going with the Army Aviation. Identify all the published adverse reactions. So you need access to whatever your reference for medications might be on the adverse reactions. Then assign a multiplier, a severity multiplier. This is really, we use the logarithmic scale from 0 to 1,000 on no concern to sudden incapacitation. We'll go into that a little bit more of what that means and how we assigned it. Develop the protocol to establish the probability or percentage of that adverse reaction occurring. Then you can calculate your severity scores, and the severity scores is what's you're gonna be able to build a reference off of. So you generate your acceptance control charts off the severity scores of your historically safe medications, and then you can utilize that chart to assess medications of interest on the concern with your environment. And again, this will all be in the aviation community of the US Army, and that is 95% rotary wing or helicopters. So what we did is we went and found all the historically safe medications. The Army has the aeromedical policy letters that are put out by the Army Aviation or Army Aeromedical Activity. And they have class 1 and class 2A, 2B medications. Really all this means is they have a list of about 30 to 40 medications that they consider safe in flight that don't require any waivers and you can kind of check off on. We then had to find a place for where we can identify which adverse reactions we have. Just the only reason we chose Lexicomp is availability to it, no other reasons. And we then listed all the adverse reactions we could find of the medications we identified, whether they were safe or unsafe. And I'll speak at the end of how we identified those medications as well on the unsafe side. But so you need your somnolence, insomnia, nausea, et cetera. And we created a Excel spreadsheet of 300 plus adverse reactions. Once we had the names of the adverse reactions identified, we had to develop our logarithmic scale or our severity scale. And so we utilized 0, as you can see there on the screen, no occupational consequence, all the way up to 1,000, totally incapacitating. And then we gave the other definitions there, and there's some examples of adverse reactions that would be associated, the difference on logarithmic scale. Here you could use 1 through 5 if you wanted. We used the 0 to 1,000 just to separate out the scores a little bit. So once we had that identified, how were we going to do it in our MARS-2 methodology? So we had the adverse reactions identified. We compiled our Excel database of them. Then for assigning the severity multipliers, we used 4 occupational medicine physicians to originally assign that logarithmic scale to each adverse reaction. Once we had this database completed, we submitted the Excel spreadsheet to the Army Aeromedical Activity Working Group, which contained the senior-most physicians in Army aviation medicine. It had from the Safety Center individuals representation on there, psychologist representation, and a spattering of other specialties. And by consensus, they looked at our list of the 4 physicians and then made changes as they saw fit and returned that spreadsheet to us to get us our logarithmic scale. So there is some subjectivity in here, but it did keep the human element, which is so important, and give us those logarithmic scales. Here's a little bit of an example of what we had. So medication X, altered depth perception was the adverse reaction, severity multiplier 100. So if we go back 2 slides, what does that 100, 1, and 1,000 mean? Well, you can see there 100 is partially incapacitating, 1,000 totally incapacitating, and 1 mildly distracting. So the next step is we had the adverse reaction listed, we had the logarithmic scale or severity score. Now we needed the prevalence or percentage. So that is again where we went back to Lexicon. Only reason we went there, it was readily available. The Army supplied it to us. And we started listing out the percentages. Some of the limitations we found is some percentages are put in ranges such as 10 to 20%. We just used the average when this was done. We also noticed that within that database, there was less than 2% and just a whole slew of adverse reactions. So anything less than 2%, 2% or less was eliminated as well, which is another limitation of this sort of model that we were utilizing. And from my understanding, the best I could get is Lexicon comes up with their percentages of the adverse reaction or probability by FDA trials and the approval of the medications. So now this is just to show you how we had all the information that we needed to develop the severity score for the adverse reaction of the medication. So in our medication X here, we have 3 adverse reactions. We have their severity multipliers, we have their prevalence. And so for altered depth perception, 100 times 12, 12% is 1200. We would then add the severity scores of up for each adverse reaction. So this medication X severity score would be 4,206. So then once we had all the severity scores for our historically safe medications, we could add those up and divide by the number of medications. So we had a mean of what the safe severity score, historically safe medications, what their mean was for safe medications, and we did use the mean for this. Then, once we had this mean, we did borrow from lean processes in industry and decided on our upper acceptable limit being 1.5 times the standard deviation and our upper control limit being 3 times the standard deviation. One thing to note here as well is the standard deviation was quite large. There was a lot of variability in these numbers. Again, that's another limitation with the model. So anything 1.5 standard deviations of the mean of historically safe or less was considered low risk. 1.5 to 3 standard deviations, or from the upper acceptance limit to the upper control limit, was considered moderate risk, and above the upper control limit was considered high risk of having an adverse complication in flight for our pilot population or crew population that we're dealing with here. And again, this is one data point amongst many when making decisions on safety for flight or not for the whole person. So one way to look at this is right here. We have charted out the severity scores and the medications. You can see there on our y-axis is a severity score. X-axis is just a generic number to separate out the different medications for you for visual representation. What I would draw your eyes to here really is these blue circles are historically safe medications that are above the upper confidence limit. And the very first question is what are these, right? And so here we have progesterone and estrogen conjugate, or your oral contraceptive pills at close to 32,000. Over here we have diclofenac at just shy of 30,000, and here is indomethacin. You're looking right around just below 25,000 for those medications on your severity score when the mean was 7,300. These red diamonds down here are the historically unsafe medications in Army aviation plotted out, and they range from sumatriptan at 45 to we have cetirizine And we also have verapamil and nebivolol in this range down here as well. But we can look at this data in a different way as well, and that's right here. Here's your safe medications by score and your unsafe medications by score. What this really shows us is the way the Army Aviation was risk stratifying their medications for safe is pretty well laid out with just a couple outliers, but on the unsafe medication, there's a whole lot more variability and spread out. So we might be able to do a little bit better job over here in this range, utilizing this model as a data point and to identify those medications we might want to take a closer look at. So I promised I'd get back to how we identified what medications we were utilizing to identify the adverse reactions. And then these medications, we also created a Excel spreadsheet, which we sent to AMA saying low, moderate, or high risk for adverse reaction in flight. And we utilized the Patient Administration Safety and Biostatistics activity. This is a Department of Defense entity that is based out of San Antonio, Texas. And what we asked for them is 100 most often prescribed medications in the outpatient setting for US soldiers from fiscal year 2013 to 2015. We wanted aviators, but the identifier within the records for aviators was not reliable. So this is all US soldiers, whether they're Army, active duty, National Guard, or Reserve. We also went into Aeromedical Electronic Resource Office. This is actually a database where all waivers for approval for flight come into, and it is underneath the Army Aeromedical Activity jurisdiction. And any waiver that came in with a medication name on it from 2013, 2015, again, fiscal years, we added to our list. And the third place we went to was Air Force, Army, and Navy aviation waiver guides, and any medication listed by name within those guides we utilized as well. That's how we had our base of medications. Again, the safe ones were coming from Army policy letters that were class 1, 2A, and 2B. So and we sent all that information down to AMA, who has accepted it and are reviewing it, but have not implemented it. They want to do a very thorough review of secondary, tertiary effects that may occur from implementing this type of process in their risk mitigation strategies. But the strengths of this type of approach, one, it's fast. There's new medications coming on the market at breakneck speed. A lot of times we do not utilize them in aviation for anywhere from the first 2 to 5 years, depending on the organization. But it would give us at least an initial data point of where this medication is going to fall just based off the adverse reactions. Again, this model is for adverse reactions, not the medical condition that is being stabilized by the medication itself. That needs to be risk stratified first, secondary the medication. The second strength is the transparency of it. A lot of times pilots, aviators, operators would be coming in and wanting to know why this medication wasn't included. And a lot of times the answer was subject matter expert. It went through a review of a panel, but this is a nice, easy way to outline all the steps that went in to the process of making this judgment using this data point. It's standardized. That's the third point. All medications are going through the same kind of model here. And fourth, evidence-based. I might be loosely utilizing this, but the evidence-based is put in there due to the prevalence that is coming from the FDA trials. But there is some subjectivity I will appreciate with the subject matter experts. The gaps is the logarithmic values that are assigned. I do look at this as both a gap and a strength because the human element really needs to be involved in the risk mitigation process here. We just don't have machines or models that are superior to the human brain in bringing in all these multiple factors on the risk in flight. Another gap is there's no case definition of these adverse reactions. So are we truly comparing apples to apples? You might have what is cognitive impairment from one medication to the next, and what is the difference between cognitive impairment and mental fogging? So there is a gap there. And the third gap I definitely want to put out is the missing prevalence for older medications. We just don't have data on prevalence for a lot of medications, so they were not utilized in the tool here. Acetaminophen is a prime example. Future use of this tool is it could be adapted to many environments, not just transportation, but the surety programs that we have with nuclear power, the radiation with the food. There's many different possible utilizations of this if we can identify the right databases to utilize in making our model work. But it does require in the future some true studying, some prospective studies versus the conceptual model it is today in looking at populations to apply it to, and then looking at end results of really what we're looking at is accident rates, but you would also want to include near misses in there. And so those are the next steps, is true prospective studies utilizing this model. That completes the presentation I have for you today. Are there any questions? All right, back to you, Rosina. So I do have one question here, and it is curious if risk was determined based on why the medication is prescribed and not the medication itself. So previous risk, we always want to look at why the medication was prescribed, and you want to risk stratify the condition first. If we're looking at atrial fibrillation, did we actually revert back to normal sinus rhythm and take away the symptomatology of fatigue, fog, etc. If that is controlled, because that's primary, then secondary, the medication utilized to treat that condition would need to be evaluated for its safety. I know that typically in Army aviation, it was the medical condition that is always primary, but I do not know if there is stratification on the medications. We're looking at the medication itself or the condition that it was meant to control. Are there any other questions? All right, hearing none, I'll turn it over to Rosina and go on mute. Thank you so much for your time.
Thank you, Dr. Corey, for your presentation. Is anyone having any questions? Okay, thank you once again for your presence and presentation. So our next presenter is Dr. George Grutzmacher from University of Wisconsin, USA. Hello, Dr. George. Are you ready with your presentation?
Can you hear me?
Yes, yes.
Let's see if I can get the camera back on and the screen on.
Yes. Now you are the presenter. You can.
There's that. Okay.
Yes, it's visible to us. You can start your presentation.
Okay, thanks. And I want to thank everyone for sticking around. It's been a interesting day, although it's always a long day to sit through lots of speakers. So hopefully we can keep the topic moving along. And let me just do one thing here to make sure. I'm going to talk about incorporating risk in occupational hazard assessments. And the key element to this is simply trying to look at the way we approach, in my case, industrial hygiene, as well as professional safety activities a little bit differently, at least than we've traditionally done. My name is George Gritzmacher. I am an industrial hygienist, an engineer, a scientist with the Wisconsin State Laboratory of Hygiene. And the primary function that I do has been to go and assist small businesses. And so this is kind of in that context of how we can work with the business community. If you will, we really ask the question why we're here. And really every day people get up, they wave goodbye to their families, they go to work. And every day here in the United States, about 20 of them are not going to come home. That's really what we're here. That's what we're really trying to prevent and address. Basically, in the United States, about 5,000 people die of workplace injuries every year. I think the most recent statistics are 2019 with the Bureau of Labor Statistics, and it was 5,333. That's 20 per 5-day week, 20 per day in a 5-day work week. That's 2 to 3 per hour if we put that all into an 8-hour workday. Now, the issue that goes with that has to do with occupational illnesses. And this is very different. Occupational illnesses, we really estimate there's 10 times as many people who die from those illnesses. There is no specific census of it. It's estimated 30 to 70,000. 50,000 gives us a nice clean number, but that's 137 a day. But that's for all 7 days of the week. That is 6 every hour, but that's for all 24 hours of the day. So basically, every 10 minutes, 24/7, 365, someone dies of an occupational illness. That's really what we're trying to prevent. And traditionally, health and safety professionals have talked about identifying and eliminating hazards. The complication is that hazards are all around us, and it's impossible to eliminate hazard. There is always some, if you will, residual risk, some risk that is still in the background. And it's really better to be thinking of control methods not as eliminating hazards, but as reducing the risk of those hazards. And in this presentation, we're going to look at a couple of different elements to that. This is a fairly short presentation, so I'm going to move along fairly quickly between the different elements. The real key here is let's kind of take a walk and talk about different kinds of hazard situations. And so from here, hazards are really anything that can cause harm in the workplace. And so let's think of hazardous chemicals. If you can, go on to the your chat there and give me a hazardous chemical that you might have. It could be at home, could be at work, could be any place. And there's lots of different options for that. Yep, I'm seeing formaldehyde. We can have a variety of cleaning agents. Now, one of the keys here is, I tend to use chlorine gas. A big cloud of chlorine gas is usually not argued as to whether it's a hazardous chemical. So that's a fairly straightforward way to think about it. Now, give me a non-hazardous chemical. And this is going to be the challenge in the real ballpark. Any of the students in my classes tend to know that I usually have a loaded question. If we talk about this, I'm seeing water, and water and air are really the most common ones. And the question here is, let's just think about water. Now, ignore drowning. I'm not talking about the safety impact, but is a drinking water, clean water out of a water bottle completely safe? And the answer is no. The issue here is the fact that every year there are people here in the United States that are going to die from drinking pure, clean water. I'm not talking about contaminated water. And so the challenge here is that we've got what's called hyponatremia, or water toxicity. And the key element comes in, you're drinking water and you're doing it really without electrolytes. So really, if we have a marathon, at the end of the marathon, frequently about half of the runners are dehydrated. They haven't had enough water. But about 10% are overhydrated. They've been exerting really heavily, they've been sweating, and they've taken water without the food or electrolytes. And so this kind of gives that whole notion that there is no such thing as a completely safe, a risk-free anything. And so this kind of gives us that approach that we need to be looking at. And so this is where I'm trying to talk and have us approach with hazard as part of that assessment, but it's the risk that is an element there. Now, when we talk about hazard and risk, what are we talking about? Well, hazard is anything that can cause harm, and risk is how much harm comes from it. In the industrial hygiene world, we can, for example, have a hazard with silica dust in the air. That's something that has had a lot of regulatory interest in the US in the immediate past. The challenge is that the risk, really the higher the concentration in the air, you can think of as increasing your risk of illness. And so that's really an element to think about. And so we come back, hazards, anything that can cause harm. We then need exposure. You need contact with that. And that's what the industrial hygiene profession does. It measures that exposure. And the result of that is risk. That is, what is the likelihood and the severity of the outcome? And here really, if you will, is sort of the elephant in the room. We end up with a situation where we have an exposure and a risk, and the underlying question is that an acceptable risk? Is that a tolerable risk? There's the language around this is difficult, but the question really comes back to at some point, you've got to say it's acceptable to take this risk, unacceptable to take more than that risk. We saw that with the previous speaker who was kind of coming up with guidelines to take a look at. We've seen that with a couple of other things today. The question is, what is that? And the complication, or one of the complications, is that risk acceptability comes from a number of different dimensions. And so what makes that risk acceptable to different people, or at least tolerable to different people? And we start with the fact that there needs to be a benefit from it. That risk-benefit trade-off is the underlying reason, if you will, for taking a risk. When we talk in the public health community, we have different ways of looking at risk-benefit, because frequently they're talking about conditions and situations where there's really very little benefit. So it's important for us to bring that risk down, whether we have a full understanding of that level of risk or not. And so to live, we've got to take some risk. To eat, whether it's hunting, gathering, farming, going to the grocery store, all of those activities have a risk. However, we have to do it in order to eat. The same situation confronts us in the occupational side. People need to have an income in order to survive in a cash-based economy, and so they need to take some risk associated with work. And the real question is that risk appropriate for that benefit? And frequently we end up with situations where individuals who have the least benefit end up needing to take the highest risk. We've seen that with, again, a couple of other speakers today who've talked about the unequal distribution of situations in society. Again, I'm not going down those ballparks. I'm just indicating these are all dimensions that are part of what we're working with here. Now, the key here is no matter what, everything we're going to do is going to end up with acceptable, not acceptable, and fundamentally, we need a benchmark. The benchmark is what's going to distinguish between that acceptable and unacceptable. The challenge we get in here is how to do that, and really acceptable to whom. There's a variety of different kinds of acceptable. The one that I end up working with the most, the one my clients tend to ask the most about, is legally acceptable. That is, it's determined by society. This is where the laws go in place. And in the United States, that's where OSHA comes in. So if you exceed in my case, the permissible exposure limits in industrial hygiene, you exceed what's legally acceptable, and now you're in violation of a government regulation. Is it culturally acceptable? That's another whole dimension. And in my world, there are community standards, there are ethics codes. I'm certified as an industrial hygienist, certified as a safety professional. I am obligated to go above and beyond those legally acceptable levels and provide the clients I work with information on what professionally we consider an acceptable risk. There are other types of entities out there. Another one, I'm a registered professional engineer. Again, there are, whether it's legally acceptable, there are things that are acceptable by the engineering profession, which I need to do. Other types of legal or paralegal types of things, the medical community, the nursing community, all kinds of different community and professional risks. And ultimately, what's personally acceptable? This is really based upon individual and community moral choices. And all of these may have different levels of acceptability or different levels of what's tolerated. And when we're dealing with an employee complaint, often it is not really a question as to whether that is acceptable or unacceptable legally. It is the fact that that employee has a different level of acceptability. And if we don't address that in the process, we are stuck with not really being able to look at and address the underlying issues that we're trying to work with. So what makes the risk acceptable? We came back to that whole aspect of benefit, but another one is the perception of risk. How do we perceive it in the world around us? And how do we incorporate values into that? I'm going to give us just a quick walkthrough to try, and that is, in general, the acceptability of risk associated with flying or driving. These are often very different for people. And so basically for every fatality we have per mile traveled, we end up with 750 deaths on the road compared to flying. Clearly, if we say that we have a statistical risk, it is safer to fly. That's not the way people perceive it. I'm not going to go deep into it, but there's a whole risk perception literature out there. And there really, as we get to safe versus risky, when we look at those values I talked about, when we look at how people perceive it, physically perceive it, we will see differences. In here, we end up with a variety of items, which for flying, end up showing generally on that risky side of the scale. When we deal with driving, they show up on the perceived safer side of the scale. And this is one of those reasons for that difference between the statistical risk and the actual or numeric risk of doing an activity. Now, we can talk about this just in the global context, which occupations are at which risk. And we've got firefighters. In the US, they're at kind of 3 times the average risk. And one might argue that for what they do for society, it might be reasonable for us to have a value system that says, yes, saving people's lives puts you at a higher, or if you're at a higher risk working to save people's lives, that's something that we're going to accept. Now, the flip is, if we look at agriculture, in agriculture, we have an exceedingly high risk. And the question is it really acceptable for society to have that high risk for us to get foods that we're eating? And so we need to look at that whole acceptability arena. I'm not going down there real far, just identifying that it's there. Now, the real key here is, what should we be doing? We should be identifying the risk of activities, that is the severity and the frequency of them. We should be building a risk matrix to look at that. And we should be assessing not just the presence of a hazard, but where does the hazard in that circumstance fall in that realm. And in general, we have frequency. How often does it happen? Is kind of what I've got across the top. Is it something that happens daily, weekly? Is it something that happens once every 100 years, once every billion years? And how severe? Are people going to die? Are people going to be disabled? Or are people going to be inconvenienced? And in the upper right-hand corner, clearly, those are high risk and are unacceptable by everybody. The bottom left, in general, people would consider those acceptable. And we have this pattern going from high to low. But exactly where the lines fall is certainly a good question. That's the unknown, where to put that benchmark line as to what is or isn't acceptable. The Industrial Hygiene Association in the United States has a strategy for assessing this. And this is the second dimension, or the second area that runs a challenge. We talk about, there's a flow chart, really starts with characterizing exposures and taking measurements. So we would go out, take an industrial hygiene measurement. We have a benchmark that we're going to look at. And we really end up with, is this an acceptable or is this an unacceptable exposure? And if it's not acceptable, we put controls in place, we go back, measure it again, and keep doing that, adding controls until it becomes acceptable. The challenge we get is that the world isn't that simple here either. There is this uncertain category in the middle. That is, we take a measurement and it's not clearly acceptable, not clearly unacceptable. Whether it's due to measurement error, whether it's due to day-to-day variation, all of these add complication to that struggle. I'm going to talk about more of this tomorrow when I talk about the how to assess industrial hygiene results. But the key is that along the way, we continue to always have to reassess things, but we need to figure out what our risk is, because we can't completely eliminate hazards. So we come back to, we've got this acceptable, we've got not acceptable. We end up with this uncertain category in between. So fundamentally, it means that we end up really with 2 benchmarks. We kind of have an upper benchmark where we know it's not acceptable above it. And in the United States, these upper benchmarks are really where the legal limits are required to fall. We have a lower benchmark. We know it's acceptable below it. And how do we approach that? Again, from a legal perspective in the United States, we can't address that. However, from a professional perspective, we can. This is where things like prudent avoidance comes in the general community addressing public health. We frequently talk about prudent avoidance. That is, it's uncertain, the risk is uncertain, so we just avoid doing it. Or we have additional measures in place because we don't know what's going on. I'm going to say that this is really the context of COVID brought us into this realm early as we started. We did not have clearly unacceptable, but we knew that we were in an uncertain category, and different individuals with different risk tolerances were choosing different levels here. At what point should you take a protective measure? At what point should you take multiple protective measures? And that's really the whole concept, the issue here. So if we come back, we've got hazard and risk. We've got that whole concept that a hazard is something that can cause harm. We have that exposure. How much are we exposed to? How much contact do we have? Which then results in risk. And that risk ends up, is it acceptable or is it not acceptable? And if you will, this also brings us to the entire arena to determine acceptability, and that is where human perception fits in, and that's where benefit fits in, and that's where value systems fit in. All of these affect where we're going to decide acceptable is and how we're going to work to address the overall issue of incorporating risk into our hazard assessment. From here, I certainly can take some questions if people have questions. I think I only have about 2 minutes left anyhow, but the key is we really want to reduce the risks of workplace hazards. And that's fundamentally the job we've got. We want people to go home on a regular basis. And I'm seeing some questions pop up. The question of acceptable risk with COVID-19 in workplaces. And that is an extremely good question. And we heard a variety of discussions here in the United States, which was talking about what fatality rate is an acceptable risk. And so where in the here in the US, when we're dealing with public hazards, we typically talk about a 1 in a million as the risk that you need to achieve to be publicly acceptable. In the occupational realm, we often work in much lower risk because, again, the benefit from having employment is there. But that's the challenge when we talk about reducing risks. And the added challenge, and that's where that uncertainty comes in, what is the actual risk, that is the numeric risk from different types of activities, and how does that affect? That's both the risk of getting an illness, as well as the risk of dying of the illness. So we find death much less acceptable, and so we prevent that much more. But what illness level and what are the long-term effects or short-term effects of illness? And again, we're back to what's acceptable. And there's no nice, clean answer. This is not something science can address. This is something that, if you will, the humanities, the discussions and working with people to get a community consensus on what's acceptable. But that community consensus is distinctly a challenge. With that, I believe I have very little time, and so I will hand it back, and we can work at getting through the end of the day.
Thank you, Dr. George, for your presentation. Is anyone else having any questions? Okay, thank you once again for your presence and presentation. So our last presentation is from Dr. Anila Bello from UMass Lowell, USA. Hello, Dr. Anila.
Hello.
Yeah. Are you ready with your presentation?
Yes, and I'd
Okay.
like to get access to share it.
Yes. Yes, it's done. You can share your screen with us.
Give me a few seconds. I'm having a hard time. There you go. Can you see my presentation? No.
No.
No. It's asking me about system preferences, so that's complicated.
Yes, you need to give the permissions to share your screen with us in your system. Yes, it's visible now.
Oh, it's visible now?
Yes.
And I will put that on the presentation mode. Is that working for you guys?
Yes.
Okay. Do you see the presentation mode or?
No, it's not in the presentation mode. Please click on that.
Let's see. Okay. I don't know how to do this. How
You
about?
can click. Yes.
Yeah, it's not okay. So if I click from one slide to another, can you see my
Yes.
slides?
Yes. Yes.
Okay, because my screen, the shared screen is already frozen.
That's
So
no
I
problem. Yes,
yeah.
you
So
can
should I
play
go
one by
ahead
one.
and do this? Yeah. So should I go ahead?
Yes, you can continue.
Yes. Hi, everyone. My name is Anila Bello. I'm a research faculty in the Department of Public Health at UMass Lowell. My training is in occupational health. I have a master's in industrial hygiene and a PhD in occupational health. I did my postdoctoral training at Harvard School of Public Health in exposure science. So I'd like to thank George for his presentation because it fits very well to the work that I'll be presenting to you today. So the presentation, and again, I would like to thank everyone for staying around. I know this is the last presentation, but I really appreciate your attendance to presenting my work. So my presentation will be focused on urinary biomonitoring of occupational exposures to epoxy resins among construction painters. Moving on to the next slide. So as I mentioned, I have been at UMass Lowell as a student and I work there now. So we have been conducting work in occupational health and safety since the beginning of 90s, and my work is focused in the past 10 years in construction health and safety. So since 2013, we have received a grant from NIOSH, National Institute for Occupational Safety and Health, with focus on reactive chemicals in construction. The main goal of this project is to minimize workers' exposures to hazardous chemicals such as isocyanates and epoxy resins. And my work today will focus on coating systems or metal structure coatings. The goal of our project is to use a data-driven approach to come up with recommendations for reducing those exposures. As you'll see later in the presentation, we document exposures, we measure exposures in the workplace, and we provide recommendations for improving the existing controls in the workplace. And we do that in partnerships with construction, trades, industry, as well as government organizations. Okay. Moving on, just a brief introduction to the coating system for systems for you that are not familiar with it. So these are metal structure coating jobs. These are workers who perform bridge paintings as well as other metal structures. Coating systems are applied to paint these bridges are two parts. It's a part A, that's why they are called reactive systems, and part B. The part A is based on reactive chemicals such as epoxy and isocyanates, where part B is a mixture, a chemical soup of other ingredients such as amines, solvents, nanofillers, and other additives. So these parts are two uniquely separated and they are mixed together in the field, and the reaction system between part A and part B happens as the mixing happening. So the workers would apply the mixtures immediately after mixing, and they do that using rollers.
So Dr. Anila, sorry for the interruption. The slides are not moving. It's on the first slide itself.
Oh, really?
Yes.
So let's go back. So okay. I'm sorry. I don't know what to do.
You need to play like one by one.
I'm playing one by one, but what I see now. So should I stop and try again?
Yes, once again, please log in and try again, as we are able to see only the first slide of your presentation only.
Okay, so I'm sorry. I don't know. So should I log out?
Yeah, once you logged out and again you'll try to log in, I will give you the permission to share your screen.
Okay, I'll try that.
Okay.
I'm back. Hi. Hello.
I'm going to make you the presenter now, just a minute.
Okay, so could you guide me step by step? So the system is asking me needs to use accessibility features.
Yes, yes.
So what do I say here?
You need to give permission to access.
So again, I have two questions. Open system preferences, not now. What do I select?
Open system preferences.
Which I did.
Okay.
And then it gives me a bunch of options here, and I'm not sure. Require password.
Earlier, what you have done, like I don't have idea about your system, to enable your screen, it was visible to us. Follow that one.
Oh, this is a Mac issue, I'm guessing.
Yeah. It was previously visible.
Yeah, because it was giving me the PowerPoint as an option. Now it's giving me open system preferences. Now it's giving me, oh, so should I open? I don't know what to tell you. I need to open. Could you hold on? I can ask for
Yes,
help.
yes. Yes, definitely. Definitely. Yes.
Ask for help. Hopefully I could get some help here.
Okay, we will be waiting.
Thank you. I appreciate Can you help me share the screen? I cannot. It's asking me the same issue, the system preferences.
I don't think it's here. Privacy, share screen. Where are you here?
Yeah, I need to share the screen.
But you don't, you share this. Okay.
I need to share the screen here.
Screen, there you go.
Yeah.
GoToMeeting needs to use accessibility. Okay.
It doesn't allow me to.
You are muted, okay.
Apple. No, don't use that.
Maybe in the system preferences, let me see.
It doesn't give me the PowerPoint, the option for PowerPoint. I did that earlier.
What, are you still in the...
I'm in the meeting, I just cannot
Did you
share.
finish presentation?
No, I haven't started.
Well, I think you need to change. This is not going. Let me see one more time here.
Yeah.
What I recommend is shut down when you
I
start.
did that. I did shut down. This is the second time I'm joining.
Open system preferences.
Doesn't allow me. How about I send you my presentation? Would you be able to go through it? Nicole?
Hello, Dr. Anila?
Yeah, so if I sent you my
Yes. Please send to Nicholas Fletcher. I will be taking him from the presentation from him, and I will be playing on your behalf.
I appreciate it. I'm sorry, my computer is not cooperating. That system preference.
Okay, no problem. It happens sometimes. I just saw online webinar, so some problem arises. There's no problem. You can send your presentation to him and let me know. I will be taking from him.
Yeah, I'll do that via OneDrive because our university has had issues in the past week with the online system.
Okay, I can understand that.
So I don't know if that explains. I've just sent the presentation. I hope the file is not too big.
Yes, I just checking now. Just a minute.
Yeah, the file is too big. That's the problem.
Send through WeTransfer as well.
Okay, WeTransfer could work.
Yes.
I apologize to everyone, especially at the end of the day. Did you receive my? Oh, it's undeliverable.
Did you send through WeTransfer?
I'm trying to do that, but even that doesn't allow me, which is kind of very strange.
Okay.
Okay, add, give me a second, add to your files. Okay, I got it this time.
Okay.
It's just downloading.
Okay. Can I know to
Hello?
Yeah, hello?
Yes, it says
Please
that.
let me know to which mail ID you are sending.
So I'm sending to the occupational Nicholas Fletcher. Okay, so.
Occupational health at crgmeetings.com.
Okay, so I'm going to use the chemical science because the first one, it didn't work, the occupational meeting.
It's not working. So I can do one thing. I will be writing you my Gmail ID of Nicholas Fletcher. You can send it to that.
Can you please? Yeah.
Yes. Mail it.
And also it could be that the one I just sent is your code. I don't know. Probably it arrived, but I'm not sure. So could you please send me your Gmail?
Yes, yes, definitely. Just a minute. In the Gmail. What? Yes, it's sent Dr. Anila.
Yes.
Yeah, you can send it to the Gmail.
I haven't received your Gmail yet.
You haven't received? You will be receiving from Nicholas Fletcher in the chat option.
Oh, in the chat option.
Yes.
I thought you were sending it by email.
No. It's in the chat option. You can send your presentation to that Gmail.
Perfect. Yes, I got that. I was looking for email. So you should have received that under occupational health at crgmeeting.com. I'll try to use the Gmail as well, but you should have received that.
Okay, I'm just checking. Just a minute.
It just confirmed that the file has been successfully sent.
Hello, Dr. Anila. We received your presentation.
Excellent. Thank you so much.
Yes, I'm getting to download it.
Apologize to everyone for this. Are you trying to share it?
I'm trying to download from WeTransfer.
I see. You probably are receiving the second one via Gmail.
Yes, I have downloaded now. Now I will be sharing my screen. You can
Yes.
let me know whenever you want to change the slide.
Excellent, thank you. And I'll try to be short, and people can reach out to me for questions if they are
Yeah,
interested
definitely.
in work. So I'll try to be quick.
Okay, just a minute. Can you able to share my screen? Is my screen is visible?
Not to me.
It's not visible. Is it visible to anyone as I have shared my screen?
It's not visible, no.
We can see now the PowerPoint starting
Okay.
to load.
Yes, yes, it's getting loaded. Just a minute.
Excellent, thank you so much. Okay, so I guess there is no need for introduction as I introduced myself. I appreciate your time, everyone. I really.
Yeah, it's no problem. It's our duty.
Okay.
Yes.
Just close that window, the
Yes,
off,
yes.
and that's it.
Okay.
Okay, you can move on to the next slide. So here I was explaining that at UMass Lowell, we have been conducting research in occupational health and safety, especially in construction health and safety, since the time of the Big Dig in Boston. And this is the approach we use. We do conduct field sampling, we collect data, we analyze the data, and we provide recommendations based on those results. And we did work with crystalline silica initially, and in the past 10 years, we have been focused on reactive chemicals in construction. Move on, please. Next slide. Here, this is a schematic presentation of the steel structures. So these are workers who perform bridge painting or metal structure coat paintings. And these are reactive systems. This is where I was talking about part A and part B. Part B being, so part B being a mixture of different chemicals, including amine catalysts, solvents, nanofillers, while part A is usually a reactive chemical such as epoxy or isocyanate. They are mixed in the field and the workers apply them via rollers, brushers, or spray guns immediately after mixing. Could you please move on to the next slide? So again, health concerns related to epoxy exposures in construction. One of the main concerns has been the irritant and allergic contact dermatitis. Most of the work has been performed in Europe, so many papers published mostly from a group in Finland, but other countries as well have documented an increased risk of allergic contact dermatitis among workers who work with these epoxy resin systems. Other adverse health effects include respiratory conditions, and only a couple of months ago, a study that was published again based on the work 16 case cohort studies in Europe had documented that construction painters have a statistically increased risk of lung cancer in comparison to other painters. However, the agents responsible for the increased rates of lung cancer among construction painters are not known. And so we talk about chemical mixtures of these Part A and Part B components, and painters are exposed to those chemicals as part of their daily routine. So coating systems are applied in 3 different layers to reach those technical specifications, to resistant to environmental conditions, anti-corrosion, etc. So the first layer is a primer that is based on high solids such as zinc oxide, etc., but that is also epoxy based. The second one is a mid coat that's usually an epoxy based system, and the top coat is an isoaliphatic isocyanate based reactive system. Moving on to the next slide. So epoxy resins, again, are polymers with monomers, dimers, and trimers that are based on this compound that's called beige or bisphenol A diglycyl ether. Epoxies have this oxirane group in their function as a functional group. So moving on, and that's where the reactivity comes from, the epoxirane group. So here are structures of the dimer and the trimer based on beige. There are epoxy systems that are based on bisphenol A, but they are not widely used. All the sites that we have worked with use beige. So this work will focus on urinary biomarkers of beige in the urine of these workers. Could you please move on to the next slide, please? So here are some photos from the study sites. There is a water tank, a wind turbine, and most of the work that we have conducted has been on these bridges in New England area. Could you please move on to the next slide? Another photo, this is a reactor dome. And this is, again, part of the bigger study because we have been working with this for the past 5 years, but my focus today will be on the metal structure coatings for these field studies in which we have collected air, glove, as well as urine samples. And these are the data. And this work has been published, so if you'd like to learn more and details about this study, I'll reference the publications. Move on, please, to the next slide. So here are the publications. They are published only a couple of months ago, within 3 months. One is the inhalation and dermal exposure analytical method, and the other one is the urinary biomarkers paper. Next slide, please. So it turns out that epoxies can enter the body not only through occupational exposure sources, but we are exposed through use of consumer products. And the main user, the epoxies are used in the coating of the food cans. And there have been studies that have looked at general public levels of epoxy as a result of these consumer products. So our group does work, so in this very simplified exposure disease pathway, we focus on inhalation and dermal exposure. We don't do any work with injection as the main pathways for these chemicals to enter the body, but we also focus on assessing biomarkers of exposure. And in this case, we are going to focus on the urinary biomarkers. To date, to the best of our knowledge, there are no data that have documented occupational exposures to these epoxy resins, BEG and its derivatives. Next slide, please. So these were the objectives of our study: to characterize levels of BEG among the cohort of construction painters in New England area. We looked at the differences between pre and post shift on urinary biomarker levels, and we compared 3 different cohorts of workers: mid-coat, top coat, and a reference group of spray polyurethane foam workers who are not exposed to epoxy as part of their daily job. Next slide, please. So here our animal studies have identified 3 main derivatives of BEG in urine, and they include this BEG H2O, or monodiol epoxide of BEG, BEG 2H2O, and this chlorohydroxy derivative. So these were the target biomarkers in our analysis. Move on, please. So this is our approach. We conduct, so we recruit construction workers, which is probably the most challenging part of our work. And once we are on the site, we do workplace observations. We measure inhalation exposures using this very unique system, and I don't have time to talk about it, but we also collect the gloves, or give the workers cotton gloves and place them in solvents and analyze those in the lab. We also collect the urine pre and post shift and analyze the urine samples for the biomarkers of epoxy, in this case in our laboratory using LC-MS. Move on, please. So briefly here showing the levels of biomarkers in 3 groups of workers. Mid-coat workers, again, I would like to remind the audience that these are workers who are exposed at the day of urine sampling to epoxy. Top coat workers have used epoxy, but not at the day of sampling, and the reference group do not use epoxy. So obviously we document here very, very high exposures in mid-coat applicators compared to top coat and the reference group. And another important finding here is that BEG 2H2O is the predominant biomarker. So next slide, please. So the first study and the only study, to the best of our knowledge, that looks at the levels of epoxy or BEG and its derivatives in urine is this Wang et al. That was published in 2012. And what the article compares is the levels in US general population in comparison to China. So we found the same results in terms of what the predominant biomarker is, and that is BEG 2H2O. However, the levels in our cohort were 4 times, the highest levels were 4 times higher than what Wang et al. Report in US general population, indicating clearly occupational exposure as one of the sources of biomarkers in urine. Next slide, please. Here, this is a busy slide. What I want to point out is that on the first left side graph, that's the predominant biomarker levels, and both bars indicate pre and post shift levels. So we compared the urine post shift among the mid-coat applicators who were exposed to epoxy at the day of sampling, and we found a statistically significant difference, which we did not find on top-coat applicators and spray polyurethane foam, which is the reference group. However, we also found elevated levels among top coat applicators, which had been exposed to epoxy probably a day or several days prior to urine sampling, which indicates that epoxy still stay in the body after a couple of days of exposure. Moving on to the next slide, please. So the main message is that we see 3 times higher levels of urinary biomarkers at the end of the shift compared to the beginning of the shift for mid-coat applicators, and that's for the predominant biomarker. And we see very low levels among the reference group. The highest level we found was 0.9 nanogram per milliliter. So we are proposing a threshold value of 0.5 nanogram per milliliter, indicating that levels above those threshold values are occupational exposures and not general public exposures. And if we find the results and compare those this guidance value, initial guidance value among the cohort of workers we sampled, 75% of our samples were above that level, clearly indicating occupational exposure as a source of epoxy in urine. Next slide, please. This is a graph of, so we also look at the type of PPEs used. They are all over the place. What I want to emphasize here is that among the respirator, the half-face respirators were the widely used type among both mid-coat and top-coat applicators. About 20% of top-coat applicators did not use any respirator. Again, there is type of respirators used and gloves used, as well as coverall varied across the sites. So there are no standard procedures in terms of what PPEs these workers are using. And in some cases, like I mentioned, the standard clothing, for example, is the most typical type of coverall. And we also observed workers working without any, with short sleeves, which was an indication of skin exposure. Moving on to the next slide. We also did statistical analysis, univariate modeling to look at the, this type of variable activity between top coat and SPF workers, and we looked at the difference pre and post shift, and we found a statistically significant, or mid-coat applicators had statistically significant higher levels compared to the other 2 groups of workers, while the other exposure determinants such as task, enclosure, respirator type, glove type did not predict those changes in urinary biomarkers. Probably that's due to the limited number of samples we had. Moving on to the next slide. I'm almost done. This is the last slide. We also are observing an increased level on creatinine, because we measure creatinine and we adjust our urinary biomarkers based on creatinine and specific gravity. What we see, and 40% of pre-shift and 80% of post-shift urine samples had these values of creatinine much higher than the WHO recommended normal range. That's why we analyzed or adjusted or normalized our samples based on specific gravity. And now we are looking at other biomarkers such as kidney toxicity to see if there is anything related to this group of cohort of workers. And I think, could you please, yeah. So the main highlights we found, this is the first study to document occupational exposures via urinary biomarkers. The badge 2H12 seems to be a robust biomarker that could be used for biomonitoring of epoxy among these occupationally exposed group of workers. We provide evidence of uptake during the work shift, and clearly our data indicate that the existing controls in these workplaces that we sampled are not efficient to prevent these workers. And I would like to thank everyone, participants. Yes, I'm done. Moving on. Our grad students, our biostatisticians who help us with this work. And the last slide is, if you guys have any questions, I know we are out of time. I would be happy to take any questions, or you can send me an email, and I hope you find this work interesting. So I appreciate your time, and I apologize again for the difficulties early.
Yeah, thank you, Dr. Anila, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone.
Okay, thank you.
Thank you once again for your presence and participation.
Thank you again. Take care.
Bye. So by this, we came to end of our day one webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoyed the webinar and gained knowledge from the sessions. And I would request you to attend tomorrow's sessions too. If you have any queries, you can mail to the concerned program manager.